introduce, well, this is the schedule. So we have planned, we started a little bit late, but we've brought ourselves 15 minutes before Catherine's due to say a few words. But should we start by introducing ourselves? So the next slide I've got, Catherine, you're first in line, so it's hard to go around the room, but I guess if we can just start by saying who we are and why we're here, that might be very helpful. So Catherine, are you happy to start?
Yes, I'm happy to start. So I think some people, maybe most people know me. I'm Catherine Carpenter. I used to run the service at Oxford, and I'm currently chair of the Division of Neuropsychology. And I'm very grateful to the others for giving us an opportunity to share with you how we might work well in the current challenges.
Thank you. So I'm Ingram Wright. I'm a couple of hats to mention. One is I'm chair of the Professional Standards Unit of the Division of Neuropsychology, and I've been involved in supporting some of the documentation that we've recently been developing, which is part of our divisional response to COVID. I'm also one of the course directors at the University of Bristol on the clinical neuropsychology training courses, so an interest in training as well. Martin?
Hello, I'm Martin Bunnage. I'm Head of Neuropsychology at North Bristol NHS Trust, and I'm also the Clinical Director of the Bristol training courses, the same ones that Ingram has mentioned. And I guess I have a real interest in how technology might be useful.
Thank you. Generally speaking, Martin, or specifically in neuropsychology? Okay. John?
Hi, I'm John Evans. So I am at the University of Glasgow. So I'm the Programme Director for the Clinical Neuropsychology Programme. And so I've also been involved with well, everyone on the page here in producing the guidelines for the use of teleneuropsychology. And that's what we're going to talk about this afternoon.
Sophie.
Hi, I'm Sophie Thomas. I'm a paediatric neuropsychologist from Nottingham and chair of the Faculty of Paediatric Neuropsychology. I'm going to be talking about some of the considerations for not just for children, but for adults with complex needs and also older adults with our colleague Rebecca Pos. Rebecca's not here just yet. She's doing some clinical work at the moment, but she's going to be joining us later.
Great. Thank you. So Rebecca can perhaps introduce herself specifically when she arrives. I was expecting her to be a bit late today. So the plan for today, I'm going to hand over to Catherine in a second, but I just want to give you a moment just to have a look at that slide and just have a think about how we're going to plan this afternoon. I imagine, like us, people are at home. We'll need to go off and grab a cup of coffee every now and again. Obviously, you're at liberty, if you're not on camera, to safely do that whenever you like and pop back. You've got the advantage that the recording will be available for anything that you've missed. I did rather late in the day build in a couple of 5-minute breaks, so they either at the end or a beginning of one of the sort of main sessions, really. So in part there so that you can go to the loo and grab a cup of coffee or whatever. We may extend those slightly depending upon how the timing's going, but they'll also give you a chance, if you've got questions or you want to engage in discussion, for you to post your questions on the question and answer board. Okay, just a reminder to use the question and answer board for any questions that arise that are related to the content. Anything that's kind of process-wise, or you're just sort of trying to get the Zoom setup working, if you can use the chat for that, that'll mean that we can keep the Q&A clean and focused on the content issues. So I don't know if anybody's got any questions at this stage in terms of how we're going to run things, but if you have, could you post them in the chat, because they're not yet about the content, because you haven't received any yet. So assuming everybody's had a brief chance to look at that schedule, it'll pop up from time to time during the afternoon. We're aiming to finish at 4, and I think we'll do so promptly. There may be some variance in the timings depending upon how we get going with both the technical issues and in terms of the way that these talks progress. Slightly more difficult, I think, for everybody, isn't it, working with this kind of interface? So we're not all quite as confident, I think, about timings. Catherine, can I hand over to you
Could I just briefly check? There were just a couple of comments of people, again, maybe this is what you were pointing out, in terms of people had said they couldn't see other people's, in other words, somebody I think couldn't see the panelists' faces, but I think, again, that's probably just how people are running Zoom on their computers. And I think it may be that it defaults to a sort of full screen, and hiding the panelists' faces. So if people want to, it's a case of going to the view options at the top on your own machine, and then selecting an option that allows you to probably take it out of full screen so that you can actually see the panelists.
Just sorry, having on that issue. So what I will periodically do from time to time is this, which should move us from a slide view back into a sort of panelist view and a view of whoever's talking. So there'll be some fluctuation in terms of what you can see. And then when I move back to sharing my screen, assuming I can find the right screen, then what you'll see, which I hope is what we've just left behind, which is the view of the slide. So when we're engaged in discussion, I'll close down the slides so you can see everybody's faces. That's a nice thing to do. But obviously when someone's talking, you'll be able to see the slides. If you need to set it up so that you can see people alongside the slides, you get a gallery view. But as John says, that's down to how you manage your Zoom interface personally. It's not something that we can necessarily control indirectly. Is that right, John? I think I've got that right.
Yep, that's right.
Catherine, are you happy to take it from here?
Absolutely, yep. So thank you, Ingram, and again, welcome to everybody who's joined us for this webinar this afternoon. It's great to have such a range of colleagues. I gather from our poll, the poll that Ingram did, that we've got neuropsychologists, psychologists in training, counselling, clinical psychologists working in neuropsychology. So that's great and welcome. And I very much hope there'll be something for everybody in this webinar. I'm just going to say a few things. I guess one of the things that I'm interested in is how are we all? I didn't do a poll on this because my sense from all the messages that I've been getting, emails, phone calls, WhatsApps over the last 5-6 weeks from colleagues and members is that pretty much everyone's struggling, just in different ways. We've got colleagues who are, some of you on the front line, doing PPE, clad assessments, making contact with patients, trying to translate medical information from ITU, phoning families, seeing if they want to connect with patients on iPad. And then we've got others of us who are a bit discombobulated at home, clinics cancelled, neuro rehab patients maybe sick with COVID, lists down, kind of not quite knowing what we should do and how we should be managing and carrying on at this time. I know I'm struggling. I ricochet from days when I'm on sort of manic COVID-19 time and I'm rushing to support colleagues to try and get a guideline out or try and respond to a trust that's struggling or something. And I have days when I feel a bit bored and irritable and tearful and uncertain. And it's tricky. Yeah, it's definitely tricky. One of the things that's grieved me quite a lot is the lack of leadership that we've had, particularly from our government, and to some extent from Public Health England, Health Education England. And so one of the things I'm hoping for from this afternoon is that we're able to give you a little bit of leadership, a little bit of sharing our ideas about how we can work as best we can in neuropsychology at the present time. And I'm very grateful to Ingram for organising the session and for others for joining us. It does sometimes feel as if we're in a waiting room or when kind of everything's on hold, and I sometimes feel I shouldn't be talking about anything that isn't COVID. But actually it is quite important that life goes on, and just to reassure you that there are quite a few strands of work within the Division of Neuropsychology that are continuing. So as well as the most immediate work in facing COVID-19, the work on teleneuropsychology, on exploring what might be the neurocognitive fallout, sequelae of COVID and ICU admissions, and you're going to be hearing more about that later. There's still work going on in terms of increasing access to training. Our events team are looking at trying to get more of these sort of sessions up and running for you, and we'd be very grateful for any feedback on how you find this afternoon, whether you find it useful format. We would like very much to put on the ACT day that we were going to have actually on this very day for you sometime in the next few weeks. We're also doing work on quality standards for neuropsychological reports, and we're grateful to Lorraine King and Abby Methley who are leading on that, and wish Abby well with her forthcoming mat leave. And Sue Copstick and Abby have been working on leadership in neurological rehabilitation settings, and they're developing a piece of work at the moment. They're collating information from UK ROC data on extent of neuropsychological involvement in different levels of case. So there is work going on. There is still work going on in the background. Just wanted to say a couple of things before we get stuck into the meat of this afternoon. The first is that the media talked a lot about unprecedented times, and I suppose in a rather sad way, I found myself looking back at and reading about previous pandemics. I've been reading Journal of the Plague Year by Daniel Defoe, which is about the 1665 plague, and also stuff about the plague in northern Italy that affected, where it decimated Milan and Lombardy, and very much the same areas that have been affected by COVID-19. And one of the things that's striking is that they faced most, if not all, of the issues that we're facing. So if you read, it's kind of interesting to read about initial disbelief, denial, cover-up, people not keeping away from other people and appropriate distancing, people hoarding food, benefactors providing food, rich people rushing off to their estates in the country and taking the plague to rural populations. And, well, perhaps not 5G, but certainly worries about superstition and what might be the reasons behind it. And I found it strangely comforting if you think that a quarter of the population of London was killed. You know, obviously the real numbers are not the same as now, but proportionally they're absolutely massive. And they got through somehow, and they rebuilt society, and they managed to do things differently. And I found that strangely comforting. And just one other thought that I wanted to share with you before we really get into the meat of this afternoon is a friend of mine mentioned to me the other day, and I think it's apposite, that as a species, we are probably the most anxious because we have imagination. So we can think about what might happen, and we can unsettle ourselves. And you only have to have been around a short time in this world to know that pretty much anything can happen to anyone at any time. And goodness knows there's a lot of bad stuff happening. But the paradox is that we're also the most resourceful, resilient, and capable species. And history's shown that in the face of personal, global pandemic and crises of different kinds, we have an immense capacity to be adaptable. And I guess that's, for me, what this afternoon's about. How can we adapt? How can we work towards being the best we can be working in neuropsychology at the present time? And if you take anything away from this afternoon, that's what I hope you'll take away. Anyway, enough chat. I'm going to hand you back so that we can carry on with the meat of the afternoon.
Sorry, Catherine, I have myself on mute. It's one of my favourite Zoom errors. It's just launching forth. Thank you very much, is what I was saying, for such an appropriate introduction, I think, just to remind us all of what we're all going through. And I think it does help set a context for our discussion this afternoon around neuropsychology, but we mustn't forget all the other things that are going on around us. So I was going to start us off with I think something that probably won't surprise people, because it's what we've been doing. It's what we've all been doing. It's what many of the people who are attending this webinar have been doing. So it shouldn't really come as a surprise to you, but I'm hoping it's sort of grounding really to sort of think about what we've been doing and what you've been doing, and maybe to share a bit of that. And I'm happy now that I've managed to get things set up technically to keep an eye on the questions. John, I think you're doing the same. So if people do have questions as things come up, we want you to feel involved in the discussion, involved in the webinar. So please ask questions as we go along. Hopefully they won't all be about how can I see more of Ingram's face or less of Ingram's face. What I want to talk about is the business that we've been doing over the last few weeks. And in terms of timescale, I think we've been in lockdown, what, somebody can probably correct me if I'm wrong, is it coming up for 6 weeks now? So I think prior to lockdown, maybe 2 weeks within my NHS role, there was a sense that we were building up to something, and the organisation began to move into a space around planning for a surge. And although messages had been present within the organisation, I think I'd had in sort of January, February, maybe one email a week from NHS England issuing guidance on identification of cases, etc. But it was very modest. And then 6 weeks ago, the volume of those messages started to increase. And I think everybody responded, as Catherine said, with a degree of anxiety and anticipation and imagination of what was going to face us. So what I wanted to talk about is how we have, in various ways, delivered business as usual. We've had concern about what is happening to our services and how can we maintain our services despite the onslaught of pressures and challenges. But also, how can we transform the business that we do in a way that responds to COVID, delivers those services as usual, but also potentially transforms the way that we think about delivering neuropsychology for the foreseeable future. And some of those things are imbued with anxieties of their own, aren't there, about will we ever get back to delivering face-to-face assessments? And we're all kind of striking a balance, I think, between whether we're seeing this as a crisis response that will start and finish, or whether it's something that is about a transformation that will be long-lasting. And so those are some of the things I wanted us to start thinking about this afternoon. I've just realised I do need to keep an eye on the time, and I've lost my own schedule. So if somebody, John, perhaps you could find your way back to the actual schedule and remind me what time I should be finishing, so I don't put us out of kilter before we get started. Catherine mentioned this data, so Catherine's seen this. This is just the survey we asked you to complete prior to coming here today. And it's just interesting to see who we are, who's in the audience. So I can't see anymore the number online, but we had 500 people register for this webinar within the space of 24 hours, which, although flattering in terms of what we were able to put on, is pretty standard in terms of offers that are being made right now. I think webinars around making a sourdough starter or learning to write haiku poetry are also being snapped up with equal enthusiasm. So perhaps we shouldn't be so flattered, but it is great to have so many of you here this afternoon, and it's great to see such a diverse audience. So we've got clinical psychologists who are involved in leadership roles, the light blue segment of this pie chart. We have clinical psychologists working in neuropsychology services, some of whom are training in clinical neuropsychology in a formal sense. Others are comfortable with being a clinical psychologist working in a neuropsychology service. There are a number of clinical neuropsychologists who are explicitly in training and qualified clinical neuropsychologists not working in leadership roles. There's a large peachy segment of individuals who are classified as other. The nice thing about this SurveyMonkey is it does, for a small fee, allow you to see the free text answers. So I know that some of the others are assistant psychologists, those other applied psychologists working in other areas affiliated to clinical neuropsychology, some of our colleagues from overseas working in a slightly different professional structure. So we have a very diverse audience, but there's a substantial proportion of those who are delivering clinical neuropsychology services in the UK in some form, and many of whom are in leadership roles. So I think of this is as close as I can get to, although I have been practicing meditation in various forms, this is close as I can get to a grounding exercise. This is about, I was thinking about where we are right now. And I mean, you'll have all seen these curves. We've seen lots of curves of different kinds, some with peaks, some with flattened peaks, some with longer peaks. And most of them are pretty scary, aren't they? And I think what this chart shows, unfortunately, I don't think I can use a pointer. What this chart shows is a phase that we're involved in, that we're in the middle of currently, which is this peak post-peak phase. We had a choice earlier on. We had some choices, and there is some criticism, I suppose, in terms of the relative success or otherwise of various strategies around, could we have done more to flatten the curve? Could we have changed things if we hadn't had Cheltenham races open a week before lockdown? But we're now in that phase where we've responded with preparation for a peak. We've engaged in various types of innovation. So the boxes at the bottom are addressing what I think, and certainly from a personal point of view and what I've heard other people say, what we've been doing over the last few weeks. So in University Hospitals Bristol, where I work, and I having talked to a number of colleagues and engaged in a sort of a wider professional debate about what's going on, this is fairly consistent with what's been happening across the land. We've been engaged in fairly significant service reorientation. So a number of our staff have been redeployed into offering staff wellbeing groups, recognizing the stress that staff are experiencing, but also offering wellbeing support to families and patients and relatives who are self-isolating, who are vulnerable, who are part of our community of patients that we serve, but also making sure that we reach out to them in terms of well-being. We've also been offering reflective groups. So these might be called debriefs, but debriefs, a rather controversial term, suggests a model for which there may well be different views about whether the evidence suggests that debriefs are a good idea or indeed make matters worse following a stressful or traumatic experience. But we've been involved in supporting staff to reflect on their experiences, both on a daily basis, but also after particularly difficult challenges that they've experienced clinically. So we've been involved in supporting a number of our frontline colleagues with that work. We've also been trying to deliver the business as usual. So in terms of service continuity, we've been looking at ways in which we might continue to deliver a service. Children that I work with in pediatric neuropsychology continue to have brain injuries of various kinds, strokes, and we have responded to their need in a slightly different way, but with no less concern about managing their journey post brain injury. We've also, I think those of us in leadership roles, I'm sure I'm not alone in this, been aware of the challenges internally within our services to our own staff. So we've been thinking about their own well-being. We've been thinking about how do we manage if we've got 20% of our staff off sick at any one time. And 3 or 4 weeks ago, there was talk about how we would manage with a workforce that was depleted by 20%. Certainly in Bristol, we've got off so far, fingers crossed, fairly lightly in terms of the number of COVID cases we've seen coming through. The number of staff who've been off sick has been modest, and so those challenges haven't necessarily been quite as manifest and difficult for us to handle as they might have been. But nonetheless, we've been prepared for those kinds of things. So we've been building services which are resilient to and can cope with, tolerate the absence of 20% of our workforce. We've also had challenges in terms of, again, on a sort of leadership and management front, how do we inhabit these rather cramped offices where we're used to not having elbow room around our keyboards, and staff who in my service quite rightly have pointed out that is it reasonable that we engage in social distancing outside the hospital, but when we come in we're in a 15 to a square meter in an office, and clearly that's something we needed to address in terms of our own staff well-being and ensuring their safety and security in a work environment. So that's meant that many of us are socially distancing or physically distancing within the work environment. So working from home, access to laptops, all the usual glitches around Wi-Fi, all of those kinds of things have required quite a significant radical change in our infrastructure just to continue with business as usual and various meetings. So that's been the position we've been in terms of our preparation, and I'm sure that I'm not alone in seeing that there's been massive innovation that's been integral to that kind of work. Our clinical director said, the kind of change that we've been able to engage with within the NHS, if it hadn't been for COVID, would have probably taken us maybe even 10, 15 years to embed some of these changes in our practice. Perhaps not as long as that, but there's been innovation on a scale that I think was unimaginable maybe even 3 or 4 months ago. Now, some of that innovation driven by, no doubt, anxiety, driven by a concern that we were going to be overwhelmed with COVID cases and that we would be buried beneath that, was no doubt the driving force. But nonetheless, there are some really positive things about the kind of innovation we've been able to deliver, not only in terms of the responsiveness of staff and the goodwill that we feel in terms of witnessing that sense of coming together to address a challenge, but also something that might change the way that we're able to deliver services for good in both senses of the word, for the foreseeable future, but also that will be massively beneficial and ways that we might have struggled to get support with generally. We're now coming out of this kind of rather crisis-driven, anxiety-fueled phase where we don't know quite what shape this curve is going to have, to a position where we are engaging in recovery and service reconfiguration. And I think of this, I can't get out of my head this kind of idea that we've just turned the tables on our services and we've got lots of broken crockery on the floor. And what we're doing is we're kind of wandering through this and picking up things that aren't quite so broken, recognizing some of the things we've learnt along the way and trying to build something which looks a little bit like the new normal, which is a phrase that's commonly used. So again, I'm sure I'm not alone in recognizing that we've got to a point in many of our trusts and services where there is talk about returning to that position, about rebuilding something. And in all that talk of rebuilding, I've not heard anyone say they think we should just rebuild things the way they were. So that now that we've turned the tables, broken some things and built some things, I think there's a feeling that we need to think about what is it that we hold on to, what is it that we keep, what is it that we dispense with, what is it we've learnt through this, and how might we be able to work differently in the future. And I've put a question mark at the end here because I think that, you know, clearly there's a great deal of uncertainty. We're still in a position where the country is in lockdown, where we're still seeing a large number of deaths and cases presenting with COVID. I personally, and in the Southwest, we've experienced a relatively light load of COVID. There'll be colleagues, no doubt, in the room, and maybe some of my fellow panelists have experienced far greater challenges in that regard and may have some comments about this. But I think we are in an uncertain position. We don't know how much mortality and morbidity that's not COVID related that might relate to late presentations with cancer diagnoses, etc., difficulties accessing treatment for the usual conditions that one sees in the NHS. We don't know what might have been the consequences of families being disrupted and incarcerated at home, and how that will influence in pediatric neuropsychology the understanding and appreciation of the behavioural difficulties and challenges that many children with neurodisability face. So those are all things that I think we can speculate about, we can creatively imagine, but I don't think we yet really have a very well developed understanding of what the future will look like. I'm endeavouring at this stage in our webinar to kind of stay in the here and now and just remind us of some of the things that we've been doing and why we've been doing it. I'd be very interested to hear people's comments. So your question and answers don't have to be questions and answers. It'd be really helpful if you can put in the Q&A any of your thoughts or reflections about how those services have been oriented over the past 6 weeks or so, what you've been doing, what you found challenging, and what you found worked. And I'm not particularly thinking about the future, but just reflecting on some of the experiences we've had. I think that will be a helpful thing for us to do. Okay. Oh, I hadn't realized I got all of this, but this is a framework that some of you might have seen, but I just wanted to draw attention to it. So I think it's, Catherine, probably about 3 weeks ago now. I lose track of time.
Yeah, it was.
But this came out on Twitter. I think it has found its way onto the BPS Division of Neuropsychology microsite. And at the end of all of our presentations, I've got some links. So if people want to get access to these resources and see them directly at the end of the webinar, you'll be able to just note down those links and go to the microsite and download some of this material. But this essentially points out, I suppose, some of the areas where clinical neuropsychology has been oriented in the context of COVID. So the first area is really thinking about our core clinical neuropsychology activities. How do we deliver assessment, management, rehabilitation of neurological conditions, the business as usual? What can we do and how can we do that? And I don't want to steal Martin or John's, Sophie's thunder in terms of talking too much about teleneuropsychology, but clearly what we were facing when we were thinking about teleneuropsychology is how do we deliver assessments and treatment without necessarily exposing ourselves and our patients to COVID-based risks. So we've no doubt raised the threshold for face-to-face contact. We've said, does this really need to happen now, or could it wait 3-4 months when we'll be in a different position in terms of those risks? And indeed, some of that work has clearly been deferred for some time because of those raised thresholds around face-to-face and any kind of assessment right now. We have maintained access to neuropsychology. I've certainly been involved in doing some bedside assessment wearing PPE. It's not ideal. It's not comfortable for anybody. It's particularly not comfortable working in pediatrics and not being able to show your face and use that to engage and reassure young people and their families. We have, and today is an exemplar of this, supported access to relevant CPD, and the DON and BPS are actively engaged in promoting webinars. And one of the things that's impressed me is just how much information is out there and how much sharing is going on. Sometimes a little bit too much, and sometimes a little bit too much of the same thing. But I think one of the good things that's happened is we can see that we can access CPD, we can access training, we can continue with those kinds of things while we're otherwise challenged in terms of our face-to-face service delivery. So that's one of the things we've been doing. We've also been developing new areas of practice within clinical neuropsychology. So we've been engaged in how do we galvanize support that's specific to the needs of patients and families in the context of COVID-19. How do we get materials out to them that are particularly helpful? So we've been engaged in delivering webinars to our pediatric population, their families, to support them most recently with coming into hospital, but in a way that's particularly mindful and cognizant of their particular challenges in terms of the need for VNS batteries for epilepsy therapy to be changed and updated and reprogrammed. Those things don't stop just because we're challenged by the risks that attend a face-to-face appointment. I think it's challenged us to work differently via voluntary agencies, via, for example, the Neurological Alliance, via Epilepsy Action, via various charities that have direct access to those patients and to whom patients will turn for advice, information and support when access to services is challenged. So it's been necessary for us to work via those routes in a much more potent way because the usual channels of contact have been broken down and fragmented. We've engaged in new areas of practice. So we've rediscovered, those of us who are clinical psychologists and neuropsychologists, and those of us with an applied psychology background have turned our attention to the foundations of our training, as it were, and to recognize that we have skills in supporting staff, we have skills in supporting our colleagues with regard to the well-being challenge. And so we've reoriented ourselves to some of that work, as well as carrying on with the business as usual of being a specialist neuropsychological service. And finally, we have signposted people to the good COVID resources that are out there. So I've already mentioned all the charities that are involved in developing some of this material. And there's an awful lot of excellent stuff out there that is very specific to individuals with neurological condition. I don't need to tell anybody on this panel or in the wider audience that, you know, when people are anxious, they're often anxious about very specific things to do with their condition. Can they get access to their medication for their epilepsy? And they're not necessarily soothed by a mindfulness app that will offer generic support around the management of anxiety and the relief of symptoms to an extent, but won't necessarily address those very specific fears that are unique to that condition. So making sure that patient populations have access to the right resources at the right time that articulate their needs in the context of COVID has been very important. And some of the agencies within the charitable sector have been much more effective, I think, in developing those resources, and that's to be expected. We're not, we ought not to be spending our time trying to invent wheels in various small population centres when those charitable organisations are in a much better position to offer something unique and well developed, well resourced in terms of the needs of their particular populations. So that's the framework that was shared by the Division of Neuropsychology, and I should have given credit. Of course, this isn't something that I am the author of. Catherine, I believe those people involved principally in this, and you'll remind me of some extra names, but Jess Fish, who's our communications and publications representative, Catherine herself was heavily involved in addressing this structure, and the other individuals on the panel today have all seen this and had a hand in shaping it up for publication. We've also had a very positive response from Division of Neuropsychology members who've recognized this as not necessarily being a surprise to them, and I'm not trying to surprise you here. I'm just trying to point out where we are and what we've done, because I think things have changed so rapidly. I'm sure I'm not alone in not knowing what day it is most days when I wake up, whether it's a weekend or a weekday, or whether I'm supposed to be going to school or work or wherever. But it's helpful, I think, given how rapidly things have changed, just to remind ourselves of the journey and for it not to come as a surprise, remind ourselves of some of the things that we've done. So I'm going to, I think, and I don't think I've got any more slides. Oh, this was just a reflection and a bridge, I think, to what I hope will be some questions and comments in terms of your experience, your responses. This is just the results of the survey that you filled in on SurveyMonkey when you registered for this presentation. So this just illustrates those areas where you have placed some or much emphasis, some being in blue and much being in red. So these are percentages that you've endorsed in terms of where your effort has been expended. So you can see the vast majority of people were responding, saying that most of the emphasis was being placed on deploying our skills as applied psychologists in a much more generic fashion within an organization. But alongside that, substantial emphasis on developing new areas of practice within neuropsychology, focusing on delivering the core business and signposting individuals to COVID-19 resources via other agencies. So in terms of that framework, it's clear that people are validating it as being a reasonably appropriate picture of the nature of our responding. It's clear, Catherine, in terms of looking at that many people have been pulled into a different mode of responding outside of conventional neuropsychology. I think we need to recognize that, but we also need to recognize the challenges when it comes to recovery of how do we reorient ourselves alongside maintaining some of that work that will, of course, go on for some time. So I think, unless I'm going to be surprised by another slide, I think that's all I wanted to say. But so it's now 13:45. I believe I've finished. This is unusual for me to finish on time. So I'm going to congratulate myself.
Ingram, you have.
I haven't. What, I finished early. 1 minute.
No, perfect. I wondered if there was a few sort of comments and come through either on the chat or on the Q&A. I think some of them fit in with some of the things you've been raising anyway, but shall I just run through a couple of them, or do you want to?
Yeah, that'd be really helpful.
Okay. So Gavin Newby just asked the question, are the signs of red tape re-emerging in the NHS now that the panic is reducing a little, which I think perhaps is a reflection of the fact that lots of things have changed and it's felt that red tape has been put to the side, but and perhaps that's a sort of how much will not come back and how much flexibility will remain.
My response to that, actually, Ingram, I do apologise. They're doing building work next door. I don't know if I'm trying to mute when I'm not talking, but it's terrible banging here. Just that the information I've had from service leads around the country is exactly as Gavin suggests. That, and I think one of you alluded to this, that Ingram did, that right at the beginning, the world was your oyster. Anything became possible, and now they're beginning to be processes to be reintroduced to kind of clamp down on what's going to be possible. But I think people are hoping that certainly some of the the wider sort of psychological medicine input into some neuro areas will continue. But I think it is reverting a bit as things improve.
Yeah. Okay, some other comments. So Tracy Ryan Morgan mentioned the important point of the.
Could I just come back on the red tape thing, because I mean, we've got 15 minutes now. I mean, people might go off and make a cup of coffee. I guess you guys are held captive, aren't you? Because the camera's on you. But we'll get a break at 2. Sorry, I'm just looking at the timing. At 2 o'clock for 5 minutes, where we can go and grab a coffee and a comfort break. But I'm very happy for us to run this as a kind of panel discussion. But just on the sort of red tape side of things, I think Martin, you're very helpful in pointing me towards some NHS information governance guidelines, which were saying that, and this is just an example, I think, of the way that red tape was set aside. So NHS information governance advice fairly early on was that members of staff are to be encouraged to share information via FaceTime, via Skype, via WhatsApp, because the risks of not sharing information were far greater than the modality with which we shared information. So that opened up and liberated a whole range of sort of communication tools that people embraced enthusiastically. Now, I think there has been a pushback, I think, as Gavin's question sort of anticipates, and we had 1 or 2 rather clumsily timed messages within our trust saying, Zoom is not approved, you can only use WebEx, or you can't use WhatsApp, you must use something, you must use CareFlow, you can't use whatever for appointment, you can't use Zoom for appointments, you've got to use Attend Anywhere. But simultaneously we were finding that we couldn't get logins for those, or the servers would break, or that we weren't used to using them. So I think there is a sort of creeping attempts to sort of re-exert some control over this, but I don't think anything to the extent that it's the return of the entire machinery of that bureaucracy. I think there's been a liberation that will be hard to turn back, but I'm straying into kind of some future oriented stuff. Other people might have some ideas about how they've experienced that. But obviously, John, you've got your, I'm happy for you to kind of guide us towards 2 o'clock and make sure everyone's comments get a fair airing.
Sure. Just Tracy was just making the point that about the emerging evidence about the neurological sequelae of COVID-19 and potentially going to impact on neuropsychological services. And so, in a sense, in the framework, we'd had the line that referred to the sort of the cognitive burden of COVID-19, and obviously that's just something that's going to filter through potentially to neuro rehab services in a variety of ways.
I was going to say something about that later on, using the papers, John, I think you'd circulated to us around neurological consequences.
Okay. And Helen Newby had made the point that in terms of sort of some of the positives, again, that they're certainly having a lot more remote meetings with, obviously with colleagues in a private practice setting, and actually that's a good thing, and saving on travel time. And that's hopefully going to continue. A few other people noted that as well. Martha Turner's, again, similarly referring to, I guess, a similar point. In our rehab service, we've moved largely online, which has in many ways been a positive thing and opened our eyes to what can be achieved remotely. And that's certainly something I've heard from several people in the last few weeks. But also concerned about the large swathes of rehab, which has been considered non-essential, and the future implications of that. So that sort of, there's some positive things about the sort of remote, but then the fact that many services have just been sort of put on hold or without very much support, I think is reflected in a number of people's comments and thinking. Just jump in if anybody, I'll run through the comments, but if any of the panelists want to jump in. Philippa Marquez is commenting that I work in a acute stroke unit and I have to carry out neuropsych assessments with PPE. Interested in knowing for any studies around the validity of testing. I think perhaps that will lead into Martin's session. And then another one from an anonymous attendee saying, so working in a neuro rehab inpatient unit, been trying to continue only essential face-to-face work, but it's difficult to assess what's essential. So this, again, this sort of debate about what constitutes essential. Personally, I've made these decisions based on the level of distress of the patient and the urgency of decisions in relation to physical health or challenging behaviour concerns also. The attendee goes on to say, we've tried to use assessments only where these can be sanitised appropriately between cases, which is also challenging. We've had the virus on the units and colleagues have developed symptoms. PPE access has been good, IT facilities poor. Considering the risks and urgency of work through professional groups such as DON seems a high priority, such that psychologists are not having to make decisions about their practice in isolation. Again, I think people feeling like, some of that whole decision making around what's essential and what's not is actually being left to individual psychologists.
Yeah. Catherine, I don't know if you wanted to say anything about that, because I think that some of the work we've been doing in terms of what the DON position should be and how much of a priority that DON work should be has been on our minds.
It has. I mean, just from a wider perspective, though, the feedback that I've been getting from people is kind of exactly as you articulated, that at the beginning somehow the needs of our neuro patients were kind of not considered at all, and everybody was going over into support of frontline staff. And then I think there's been a bit of a sort of recognition or swing back on our behalf to say, hang on a minute, actually our neuro patients are every bit as vulnerable. And I agree with the delegate who said it's not great that those needs are considered non-essential, and it's very difficult. I mean, I know that actually our medical colleagues are struggling with the same thing. All research across the UK has been stopped. It has to be COVID related. I mean, the world's gone a bit bonkers, and it's difficult. I don't think it's the division's place to be too directive, but I'm keen that we connect and see what options people have come up with and how people are doing things elsewhere. And quite a lot of what I've been doing has been linking up service leads with different people across the country.
Martin, is there anything, sorry, I don't know, Martin, is there anything you wanted to add about the red tape? I'm just looking at some of the comments, John, about red tape. Obviously, there's been, I think, quite a significant variance, I think, in how different organisations have responded. I think in Bristol, certainly in University Hospitals Bristol, we have two large trusts. Martin is head of neuropsychology in one of the other large trusts, may have very different response, possibly, Martin, but my experience has been that the investment in IT was crucial. I had some lovely conversations with IT people who are normally run ragged, but they seemed to be the most polite. Couldn't do any more to help us to provide laptops, iPads, webcams. Although this stuff was in short supply, we were promised and were delivered, in a very short space of time, tremendous additional resources that supported us to be able to do our jobs. I imagine the experience has been incredibly variable, but I think that investment was clearly made early on and was seen as crucial to our responding. I suspect other people have had much more painful sort of responses within their trusts and services.
Sorry, very similar. So we've had a very easy ride when it comes to technology, actually. Surprisingly so. I think it surprised everyone a little bit just how easy it is when the willingness is there and the financial backing to actually, afford these things materializes. I think certainly in the trust I work, the IT people have been fantastic, and they've been very helpful actually in solving what are potentially quite complex problems from an IT point of view, but coming up with solutions. So, opportunities to have remote video calls to patients in ward beds to reduce the amount of moving around unless it was absolutely necessary. That sort of thing is surprisingly straightforward. Things that I have been interested in for a long time that were 6 months ago impossible. If you ask anybody, there's just too many reasons why not. All of a sudden, everything becomes surprisingly straightforward, which I guess is nice. I would worry about the slow creep of returning bureaucracy and red tape challenge, and suggest we all resist it with all of our strength, because the liberation has been great. As a professional activity, the freedom to actually use your imagination and do the things that you would do if you were able to make all the choices has been really, really valuable.
Another just related comment from Andrea was about how many memory assessment services were being put on hold or with assessments postponed, with concerns about the validity of the neuropsych assessments done remotely. I think that question ties into some of the other things that are coming up, and perhaps did you have a poll answer about that, Ingram, or how many people would sort of change their? I can't remember if you'd done a poll on that one.
So I'd done that poll. I mean, it wasn't very clear in terms of the way I presented it, but the poll that I did was really around, where people had moved in terms of that framework, where had been the emphasis, and I didn't want to burden people at that stage with sort of too many questions about the detail of what they've done. I'm sure that people, if people are interested, we can. John's got a poll related to teleneuropsychology that I'm going to bring up in a minute, which will give you something to. I don't know whether you want me to bring that up before your session, John, or afterwards, but you just let me know when you want me to bring that up. But in terms of our current knowledge of what people have been doing, it goes no further than this, I think, Catherine. It may well be that from a DON perspective, it would be helpful. And we've been thinking, haven't we, about, well, what can we offer at this stage? And maybe in the context of recovery, being able to take stock of what people have done in a much more detailed way, and then support people in terms of planning for the future might be something that we need to do. We've accumulated a lot of work, haven't we? Because if people have been moved into other services, there'll be a backlog, in essence, of rather sort of conventional work that we needed to do and was important, but has been deferred for some time, and that's going to present a challenge to services. I mean, I, like Martin, have had a very positive experience in terms of bureaucracy and red tape banishing, but we do need to rebuild some governance structure around what we do going forward. And I think it's important we don't let it creep too forcibly into our practice and constrain us too much. I think this issue of threshold, it's obviously something that you would consider, John and Martin, I think, in terms of tele-neuropsychology, and I think it's something you intend to touch on. I'm just looking for a nod, really. But I suppose my view is we've always had to manage thresholds, haven't we? We've had long waiting lists. We've had demand for our services that's often outstripped supply. We've had to prioritize. And I think that the challenge as I've experienced it has been that that's just been brought into much more acute focus, that we ask that question much more explicitly. Is this necessary, and is it necessary right now? And is there another way to do it? But I've always encouraged us to address that within our service, because our resources are limited. We can't necessarily help everyone to a gold standard. You know, we'd often triage and offer something, and then if problems evolve, certainly in pediatrics, we would then pull people back in and galvanize more resources to support them. So I suppose it really depends for me in terms of how services are organized and how equipped we are to engage in a sort of a revolution in terms of our triaging of the importance of doing a face-to-face assessment. But I know it's something that Martin and John will touch on, so I didn't want to go into too much detail. But I suspect that I'm not the only one who's been doing a little bit of face-to-face assessment with PPE on, because that child, that individual in front of me, absolutely needed some form of assessment at that point in time. And it just wasn't possible to train up nurses to do that indirectly. It just wasn't possible, given the age and complexity of the interaction required with the child, to do that via FaceTime or some other medium.
Really interesting point here, just to the little conversation going on in the chat, which is certainly relevant, I think, to Martin's and my session. So one of the delegates was saying, I was wearing a mask when testing memory with a 72-year-old patient. And the patient appeared to be a bit confused when I was reading words, so list learning or story recall, and pointed to the mask I was wearing and the fact that it was difficult for him to try to remember the words without seeing my lips move. This seems to be a confounding in administration of verbal memory tests, and I was wondering if anybody had similar experiences. And actually, Rebecca made a really good point. Rebecca Pos responded and said, in her trust, we're pushing for masks with visible mouth sections. So I think we need to push nationally for these types of masks for people who are hearing impaired or cognitively impaired, and those who will only have social contact with people in masks. And then actually Helen Newby again helpfully replied as well that actually she'd done the arbands via Zoom and found it had worked well. And in fact, it raises that interesting question about maybe in that situation a remote assessment is actually more valid than an in-person, but if you're covered up sort of thing. So it raises really interesting questions about what's the most valid version, and just because you're in person actually doesn't necessarily, if you're having to be, at least have some sort of PPE involved. So interesting, but that leads into Martin's presentation. Again, somebody else making the point that doing a psychotherapy session with a mask, and the patient told me that she couldn't read my face and didn't like it. So again, another perfect example where actually a remote session might actually be more effective than an in-person with mask.
Yeah,
lots of chat coming in on that point there. Some really interesting. Just also on the Q&A, Nigel Schofield just saying, in the rush to clear beds in case more ward space was needed for COVID-19 patients, many patients in active multidisciplinary rehab, neuro rehab, were discharged home prematurely in ways that could have previously been as unsafe, with inadequate care, support, equipment provision, no facility to continue active occupational therapy. Rehab services have been closed down, staff redeployed, etc. Cognitive, physical and psychological costs of this in the short and long term are unknown and may well lead us to dealing with unfamiliar new challenges once a more MDT approach is possible. And patients eventually get access to that. So again, yeah, sort of a possible storing up of difficulties of a little phase or of several weeks where people may have been discharged home before they would normally be.
Okay, welcome back, everyone. So I'm going to hand over now, just making sure these slides are working, to Martin Bunnage, who's going to kick us off with teleneuropsychology.
Thank you, Ingram. And hello to the virtual audience of all 336 of you, according to my computer. It's a bit hard not being able to see your faces, but I've done my best to build up a picture of the audience. And I'll attempt to convey things in a way that's helpful to everybody. Now, Ingram, can I advance the slides here myself, or do you have to do it?
Sorry, I didn't mention that essential thing. Yes, you'll have to tell me when you want the next slide.
Okay, next slide, please, Ingram. Okay, thank you. So, in essence, this talk, I mean, it's a very short talk, but in essence, what I was trying to do was remind us all of the threats to validity that exist in all of our work and always have done, and then try to address some of the issues that come up when you think about face-to-face assessments, but with PPE, which lots of people have mentioned in the chat, which I think hitherto we'd probably always assumed was going to be a very straightforward thing, but actually in practice it's proving not to be, and a tele-interaction, and try to draw out what the threats are to validity in all these scenarios to, I guess, remind us and ground us in the starting point. Then I'm going to look at just a couple of little studies that have been persuasive data for us in the past, whether we explicitly recognize that or not, about what equivalence can mean in terms of the use of tools created in one way in a different way. And along the way, try to draw on some of the broader considerations I think are relevant. And I think some of that's already been touched upon by people's personal experiences, but I think it's a helpful starting point to kick us off. So if you could give us the next slide, Ingram, this one I'll probably stay on for quite a long time. Now, I hope this is visible to you. I went through various iterations of how to try and convey all of this, and this is the best I came up with. It's colorful, but I'm not sure whether it's actually that legible. Nonetheless, it's the starting point for me. So what I want to do is just talk you through what it is. So we have our broad heading at the top, threats to assessment validity, and then I've sort of painted what I see as three modalities or ways of working that we're thinking about here. We've got our business as usual over on the far left, which highlights threats to validity that are common to every way you think about doing an assessment. I've then tried to draw out some of the things that are specific to a face-to-face interaction, but with PPE, and then some of the things that are specific to a tele-interaction. And you can see I've tried to cover various areas, most of which are reflected in the BPS document that we contributed to. So just to remind everybody, none of this is going to be new, but when thinking about our normal ways of working, there are many threats to validity that come from ourselves as the examiner. You know, are we administering the measures correctly? I mean, by the manual correctly? Have we scored it correctly? Do we understand the test that we're using, how we might use it in our formulation? Are we familiar with the client group we're testing or evaluating? Do we use supervision and CPD appropriately? And our own biases in the way we perceive our work, the way we perceive the value of tools, the way we perceive psychometric properties and how that influences our work. So those threats, which are potentially large, are present no matter how you do your work. And to give you some sort of feel for what I mean by that, there are research papers looking at how reliably waste protocols are scored by clinicians. Surveys where a range of clinicians of different experience and qualification are given the same test protocol to score, and this may or may not surprise you, but the scores are not always the same from all of these individual people, and sometimes the magnitude of those differences is surprisingly large. We then move on to examinee factors. Does the person we're interacting with have sufficient sensory perception to be able to interact with us in a way that makes the evaluation valid? And this is true whatever modality you use. Can they communicate a response to us that allows us to conduct our assessment? Are they engaged with the work that we're doing? Are they engaged with the assessment tasks? Are there distracting comorbidities present? Not sure about the heart, Ingram, but anyway, nonetheless, distracting, is that a distracting comorbidity for me? Present, such as pain or fatigue. Okay, very good. Things that can get in the way of the person interacting with the tools in the way that they were intended. Factors that were not present in, for example, the normative group for which the tools were originally evaluated. Other things like stress, anxiety, distress in that person. Potentially large significant factors around culture and language similarity, similarity of the individual being evaluated, and the normative standard for the test that we're using. Level of ability or impairment of the person, so do the tools that we're using at this particular time match that person's capabilities? And of course the impact of pre-existing limitations. So if somebody has significant dyslexia prior to anything else that's happened to them, that will have an impact on how we understand verbal tools in that individual. We move on. Generic information about the environment. Is it too hot? Is it too cold? Is it distracting? Is it noisy? Just think about every test manual talking about how tests were normed, and obviously it's a quiet room with no distractions. Well, anyone who's worked in a hospital and ever evaluated somebody on a ward knows it's rarely a quiet environment with no distractions. These are threats to validity that we have tolerated for a long time. Factors such as third-party observers, including the recording of things, covert or overt. This is something that's brought up quite a lot in relation to tele-administrations, but it's equally applicable to any administration of an assessment, and it's a relevant point for every evaluation and the contexts. People believe, I think, that it's easier for stuff to be recorded in a tele-administration format, and that might well be true. But I think the mustard flowers case in the UK, for example, highlights that whilst it may be easier to do it with a tele-administration, it's perfectly possible to do it in a standard face-to-face administration, and has indeed occurred. And I was inspired to look at covert recording devices as I was researching for this presentation. And I think on Amazon for about 40 quid, you can buy a very serious James Bond style pen that will video and audio record whatever you want to point it at, which I thought was both interesting and scary in equal measure. Then we look at assessment validity more broadly. So are we actually able to address the relevant question? And this has got nothing to do with the modality with which you are administering your evaluation. Is the question one that we can address? Have we chosen measures that can actually help us address that question? Have we assessed the relevant traits and processes that we think are important? This matters because not all questions require the evaluation of all things, and that has implications for different modalities of administration. Clearly, if you want to do speech and language evaluations that involve the person being able to see your face, that's clearly a problem when you're using PPE. Equally, if you're trying to do an evaluation that needs somebody's physical motor response, that can be quite tricky when you're doing things via tele-administration. But I think the important point here is not all questions need all things to be evaluated for you to make some progress. And indeed, on some questions, you could probably answer them without involving the evaluation of things that are tricky by these different modalities. So we have to be thoughtful about what is it we actually need to be able to measure in order to address a question, rather than think what is it that we can't do, because that may or may not be important. We need to look at, as always, the reliability of our measures, any ceiling and floor effects, and the appropriate normative comparisons. Those are quite relevant to the different formats of administration. I'll talk about that in a minute. And then the usual things around diagnostic validity, and indeed our connection with the research evidence base around the validity of our assessments and evaluations in relation to our opinions. All of that is relevant, whatever modality you choose, and all of it represents potential and sometimes quite significant threats to the validity of what we might do. The interpretation section beneath that, you can read for yourself. We all know this stuff. It's just there because, this is relevant stuff and has an implication for how valid the outcome of an assessment might be. So that's just to ground everybody in the myriad of threats and complications of doing an assessment full stop. And so we then try and port some of that into these different modalities and have a think about what the implications might be. So I've taken as a starting point, face-to-face in the way that it was done 4 months ago isn't going to be happening in the next week, probably isn't going to be happening in the next 3 months, might not be happening in the next 6 months, perfectly possible for some of our very vulnerable groups. It might not be happening in the next 12 months. So we were left really with 2 choices, and that's face-to-face with some form of PPE, most likely. So I think the choice we're sort of left with right now is face-to-face with PPE versus some form of tele-administration. And which one of those is better will depend, I think, on a calculation that you might make around risk and threat to validity. So when looking at examiner factors, we ought to consider, to look at the impact of PPE for us as examiners. So what is it that we are able to do less well when wearing PPE? How distracting might that be for us? We need to think about the practical considerations of face-to-face appointments, infection control regarding test materials, the room we use, even down to, and maybe this is extreme, but it's certainly something to think about, you know, the materials that we've used, the pieces of paper that we've used that have been handled by all of these people. That, you know, there is some evidence that those can be harbingers of virus for a period of time, and do we have to have some process for quarantining all of that? This is all you know, stuff that we need to think about. If you compare that to the tele-administration process as an examiner, I think the most significant thing is the impact of video calls on the way we communicate. So people communicate differently, and you have to get quite practiced at seeing a reflection of yourself and not being distracted by it. And I think when it comes down to delivering actual assessments remotely, I don't think I can stress this enough. Familiarity with the technology and how you actually do it is paramount. I think people have one of 2 reactions. They either think it's all too difficult and therefore I'm not going to do it at all, and therefore it's just nothing I'm going to think about. Or they potentially have more of a blasé view on it, that it's all relatively straightforward. As Ingram is demonstrating ably, it's not as easy as it appears, and you can press the wrong button very simply. Very easy to get carried away with your stars and hearts, but thank you all.
I'm very sorry, Martin. I've lost the controls in front of me, so it's not a deliberate attempt at sabotage.
I thought it was a purposeful
no.
demonstration.
Nothing deliberate about this whatsoever. I'm going to keep my hands to myself.
All right, but it is. I mean, it's an important point. It isn't actually as easy as it seems, and it isn't easy when all of a sudden you're getting flustered with something that's not quite working, and you forget what you're supposed to be doing, which is interacting with the person. So familiarity with it under extreme circumstances is probably a necessary skill before you really feel comfortable doing it. And then we've got to think about simple things around the quality of our data connection, because there's nothing more distracting and disarming than a disconnection between the video, the audio, or things slowing down, or things breaking up. That puts people off immediately, you know, the examiner and the examinee, and it makes for a very frustrating interaction. So those things are important to get right at the beginning. If we look at the examinee next, thinking about PPE, are we expecting our examinee to wear PPE? If they don't wear PPE, what are we saying to them when we do? If they do wear PPE, who's putting it on them? How are we thinking about the impact of that on their perception of the danger of this interaction, whether it actually be dangerous or not? I think putting on PPE just in case potentially makes people think things are more worrisome than perhaps they are. Many people are already distressed and worried, and some of our client groups are particularly vulnerable to those feelings and or to the distraction that might come from doing things in a way that doesn't feel very natural. And so I think we need to give considered thought to the real impact of those things on how well somebody's actually going to be able to engage with our assessments and the impact of validity. So that's an example of you know, an engagement issue, not one that we're more familiar with, you know, not one that we would evaluate with symptom validity measures, for example, but one that I think is clearly has the potential to be quite distracting and troubling for people. On the tele side of things, we have to think about the familiarity of our examinee with the technology that they're using. Now, most video call facilities have been quite good at making the requirements for the person receiving the call to be as low as possible. You know, most of the work is done by the person sort of managing the call rather than the person receiving the call. So I think those, with some practice and for a good number of groups, are potentially easily overcome. I think there are some groups where this might be very problematic, and we might get around that with people facilitating those calls, but then we get into the third-party observer validity threat that's always present. So there's a trade-off there. I think when we look at people coming to us, physically coming to see us wearing PPE or not, we do have to think about the ethics of that. We're asking people to travel, potentially at a time when they're being encouraged not to travel, or we accept that they can't travel, and if we don't do a tele-assessment, we're not providing them with any form of evaluation. And presumably that evaluation was on some level considered important. Otherwise, you could ask why it was asked for in the first place. So although we can postpone things into the long grass for a period of time, I think there comes a point where we have to reflect on the cost of doing that. And if the time frame for restrictions is many months, we have to really think about what are we saying to people if we're going to just postpone all of their all of the clinical service that they were asking us for in the first place. I think that sends a very interesting message about how we value our work and how we value the importance of our contribution to them. And although we might have a perspective on it, it would be interesting to get perspective from those people themselves. You know, and many people I think are starting to do this by asking people, would you like to have an appointment when face-to-face could be resumed? Would you like to come in, or would you like to do it remotely? I think that's really important for patient choice, and I think that might be quite informative for helping us balance our own perception of what our particular client groups think of as more risky or more valuable. Okay, we then get to some environment issues. One of the things I think that is potentially problematic about tele-administrations and requires quite a lot of setup from the outset is thinking about how the environment is not within our control. So when people come to us, obviously we set up a room in a certain way. When we go to them into their house via some remote technology, we're not doing that. We don't have the control over that, and we might feel that we can't ask people to do various things because, of course, it's their environment, not ours. But I think that becomes a conversation about you know, the threats to validity and what we really need to have happen. And if people are unable or unwilling to do that, then I think we have to calculate how valuable, how big a consequence that is for the validity of our work, and decide partly whether or not it can be done. So, you know, I think there are real challenges to not communicating with people ahead of time, making it very clear what it is you need them to be able to do in order to have a successful assessment. You can't just beam in with no preparation and expect them to have worked out all the things that need to happen, you know, and not have the dog in the room and not have this thing going on, or the telly, or whatever it is. All of those things are important. And I think we have to think about the cameras. Most of the cameras don't have a wide field of view, which is something that people worry about. We don't know what else is going on in the room. This is something that people get concerned about with third-party observers or people recording assessments. I mean, on one level, I think we have to trust people if we ask them and they tell us that nobody's recording the assessment and there aren't a film crew sat in the corner. I think we have to believe them. Or if the evaluation is one where that's not such a straightforward thing to do, we can always ask people to, you know, rotate their camera around and show us. That's not beyond the possible. It would be nice if some of the cameras had a slightly more wide-angled view, but that just isn't the way it is, I'm afraid. Okay, we move on to So I'm talking deliberately quite quickly as it's quite a short presentation. I'm just trying to get through these things. Looking at assessment, I'm not aware, and somebody asked this in the audience, I'm not aware of any validity studies that have asked people to administer tests in PPE. I don't think anyone thought it was a thing before now. So I'm not aware that it's ever really been compared. So there are, as far as I know, no validity studies showing the comparability of the face-to-face and PPE administration of something with an old-fashioned face-to-face administration. And it's true that the measures were not normed with people wearing PPE. When looking at the tele-administration, we're in a slightly better place, although there are still limitations. The measures were not normed using a tele-administration method, but we do have some reasonable validity data around some commonly used measures showing some comparability, and John will talk about those in a lot more detail. But we also have some limitations. There are things that don't lend themselves readily to a tele format, and some things for which the validity data is less good. I think there's a practical consideration amongst tele-administration that we really need to think about. And actually, now that I think about it, it's probably equally applicable to PPE. You have to work out how you're actually going to do it. So there are times, some of us have done these things, I guess. Some of us have tried, some of us may have not yet. There is a need, just like there is with a face-to-face evaluation, to get slick at knowing where your hands need to be and what you need to be doing next and what that button does and where all the things are, because it's very easy to get sort of in a state where you might be a bit flapping around, not quite understanding what it is, and not having the thing to hand, and it all looks a little bit less professional. So just like, I guess, in any assessment, practicing and being slick at what you're doing is pretty important. And it isn't a straightforward swap of just doing what you've done in a room, but with a camera pointing at you. It isn't so straightforward, and you have to think about some of the subtleties and nuances. Some of the things around screen sharing are, I think, a little bit technical. They're not insurmountable problems, but they are a little bit technical, and you have to practice it and be familiar with it. As I won't comment after this, Ingram, but as Ingram was demonstrating, screen sharing can trip up even the most seasoned professional. It's time for the next slide, Ingram. Thank you.
I'll do my best, Martin. Would you like some little stars and hearts on it, or would you just like the slide? Okay.
The slide would be lovely. Thank you. Okay, so this is well, I've got stars and hearts.
Oh, you have.
This one is.
Yeah.
What I want to do here is just convey some of the things that we have used in the past as convincing evidence, whether we've known about it explicitly or not, but things that we have considered acceptable as evidence to show comparability. So the first one is to look at the Wace and Wims 4. We use the norms that were generated from the American census sample, and we use those because we are convinced by a comparator study which uses a much smaller number of people, so 240 for the Wace and 181 for the Wims, which is a census sample, and various statistical comparisons are undertaken to establish that those samples were comparable to one another, which was used to convince us all that we could use the US data. What I wanted to highlight, because I think this is relevant to some of the things John's going to talk about, those comparative studies show there are differences sometimes, but those differences are around or less than a Cohen's d of 0.1 for some of the measures, and for some they are very small indeed. But just to have that in your head as a metric for convincing data in the past. Next slide, if you would, Ingram. This comparative study looks at pencil and paper administration of the Wace and Wims versus the Q interactive administration of those same measures. These are both face-to-face, but using different modalities. These are much smaller n's for the comparator studies, but this has been put forward as convincing data for the equivalence of these measures. And in these particular comparisons, the effect size with the biggest differences was around Cohen's d of around 0.2, so obviously bigger than the other study, but that was considered by Pearson as indicating that Q interactive administration yields equivalent results as paper administration. So effect size is around 0.2. looking at the time, I won't go into the details of the bottom one, but it was quite interesting to notice there were some differences that seemed bigger, and then they tweaked a few things and most of them disappeared. So, it is important to evaluate, to establish that things are comparable, because certain things can crop up that you weren't necessarily expecting to have an impact, but do, such as how the software interacts with the clock on the iPad, or how the image was more blurry when looked at through an iPad compared to on paper. But those things were tweaked by Pearson, and again, point 2 is their sort of criterion for comparability. Which leads me on to my last slide. So when moving forwards from here, I think we've got a few choices. We either postpone things, do things with PPE, or do things remotely. I think we ought to think very carefully about postponing things for too long, as I'm not sure that sends the right professional message to our patient groups, which leads us to a PPE versus remote administration question. And I think in answering that question, we probably need to think about more than just, is it valid? Can we do it validly? And have a broader ethics and risk evaluation of the benefits and costs of doing things differently. I don't think there's a perfect solution, but looking at the threats to validity of face-to-face, I don't think there was ever a perfect solution. I think we're just shining lights on things that we've taken for granted and just become so comfortable with, we've forgotten to look at. And then it would be helpful, although I don't know whether this will ever really happen, but reaching some sort of professional consensus about what we think is enough data to be convinced by the equivalence of doing things in one way versus another. Partly, I would like to think that we can reach a consensus about what is acceptable to be done in a remote tele fashion, because COVID aside, I actually think those approaches allow us to engage with client groups that we probably don't engage with in ways very much at the moment, because we inadvertently put barriers up to their engagement by virtue of their need to come to us, stay there for a long time, do various things that are just not easily possible for some of our client groups. So if we can reach that consensus, that would be marvelous. I don't know whether we will, but it's certainly something that we should strive to do, and perhaps the COVID experience is a springboard that might motivate us to look at it. Thank you.
John Evans is going to talk to us about practical considerations in the delivery of tele-neuropsychology. And then if people, I am monitoring the questions that you're all asking on the Q&A and the chat, and my colleagues are very helpfully chipping in with some answers themselves, which is fantastic. John, I'm going to hand over to you. We've got a bit of flex on time, so don't worry about that so much, and I'll just keep an eye on it, and we'll have some time for questions at the end.
Okay. Thanks. Yeah, just let me know when you want me to start. Okay, thanks, Ingram, and thanks everybody for being here. If you could go on to the first slide. Thank you. So just before I start, so I'm going to focus on some of the practical considerations in doing tele-neuropsychology, and Martin's already touched on a few of these, which is great. So just to reiterate a few of those. But just to acknowledge the people that have contributed to this, really. So the group from the DON Professional Standards Unit that are listed there, who contributed to developing the guidelines that I'm going to refer to. I just want to mention Rennie Stolwick, who's in Monash in Melbourne in Australia, who's been doing a lot of work on this topic, and he's been very helpful. And also, I've been talking to colleagues over the last few weeks just about their experiences of doing tele-neuropsychology, and I've tried to incorporate a few really helpful comments and feedback. Karen Taugid, Steve Meldrum, and Nicholas Priestley. Okay, next slide, please. Okay, that's it. Thank you. So just a note that when we're talking about tele-neuropsychology, there are different models of tele-neuropsychology. So if you're dipping into the literature and you're thinking, I'm going to go and have a look and see what's been done, and again, Martin was touching on the validity of assessment tools. A lot of the literature is focused on what we might call the remote here. So here, this is again from Rennie Stolwick's work. So we can think about tele-neuropsychology being done in what's called the remote, or within clinic, or home. Now, mostly what we're thinking about now and what people are trying to do is the home one, and the one on the right there. But a lot of the work to date has actually been done under a sort of remote context. And remote really means a situation where you have the client and the clinician in separate hospitals. So this is really work that's been done to try and support people in more rural or distant parts in order to gain access to services. So a lot of that work's been happening in Australia and the US. So in that situation, you usually actually have a trained assistant in the other hospital or clinic with you as a clinician in another clinic somewhere. Now, obviously, that's very different from the sorts of things we're talking about now, because those sorts of things don't fulfil the social distancing requirements and are not the thing we're focused on now. The within clinic option is an interesting one. So this is basically where you would have a clinician and a client in adjacent rooms. So here, of course, you have to bring somebody into a clinic, but in order to try and maintain social distancing or physical distancing, what you do is you have your setup of a camera and a screen in one room, and you're in another room. So most of the time you're not actually in physical contact, but it means that you do have all your other sort of facilities around. So there are less restrictions on what tests you can use. It doesn't require an assistant and so on. So that's maybe something that's worth thinking about, again, particularly as things, if we're in a transition phase going forward. But of course, what most people are sort of trying to have a go at is what we might call the home format, where you've got the client at home, the clinician's either at home or in a clinic. And of course, that's the one where there's most restrictive in terms of the implications for tests. It may be more difficult for people with cognitive impairment. I'm going to come on to that. But of course, much better as far as travel and social distancing. So I just wanted to sort of highlight that when we think about the literature, certainly that there are different models, and it's worth being clear about that in terms of when you're thinking about literature. Okay, next slide, please, Ingrid. So what I'm focusing on is a set of guidelines that a group from the PSU developed for the DON. And so these are a set of sort of guidelines for use of teleneuropsychology. Okay, next slide, please. So the headline, I suppose the headline for that was, from the guidelines, was the DON supports the appropriate use of remote technologies when undertaking clinical neuropsychology work in the context of current COVID-19 pandemic. And Catherine mentioned at the beginning, in a sense, the importance of trying to give a sense of leadership and a reassurance to people thinking about this and dipping into the literature, but actually having looked through the evidence so far, talked to colleagues with experience in this, but actually there is a level of support for doing this from the division. Next slide, please. And certainly when we look to the big test companies, so Pearson, Parr and others, in a sense, have also helpfully offered support for this. And so Pearson have offered, produced their letter of no objection, which really, in a sense, highlights that they are happy for clinicians to use teleconferencing software and tools to assist in the remote administration of their tools. Now, there are restrictions to that, particularly in terms of things like copying and recording and how you present information, but I'll come back to that in a little while. But again, in a recognition in the middle of a pandemic, some flexibility from the big test companies was good. Next slide, please. However, I guess that it's also important to highlight that this has to be done on a case-by-case basis. So just because the DON and people are saying, hey, teleneuropsychology is a good thing, it doesn't mean to say this is going to work for everybody by a long way. And so the questions that are being asked need to be thought about carefully. The urgency of the question that needs to be addressed needs to be thought about. The practicalities of doing it with each individual person need to be considered. So this isn't going to work for everybody, and that's vital to make clear, and that was clear in the guidelines. Next slide, please. And again, it's also critical that the guidance was given, but this should be interpreted in the context of your local organisation guidance. So that's if your local NHS service or whichever organisation you're working for, you obviously need to comply with whatever the local requirements are for your employer or other host organisation. Next slide, please. And again, Martin's touched on this issue with the question of validity and the evidence, the reliability of our data that we collect from teleneuropsychology. And the point is I'm going to make is that published studies do indicate that remote administration of some neuropsychological tests can produce reliable and valid results, though the evidence base is limited. So again, this is a sort of a balancing between the need to do practical things and being cautious in our reading of the literature. Next slide, please. And again, Sophie and also Rebecca are going to think about issues about the assessment of young children, those with intellectual disability, and older adults a little bit later. Next slide, please. So in the guidelines, what we've done is we've broken them up into sort of separate sections. So there's one about technology, and that's the first part. So obviously, again, you have to think about what does your health board of trust allow. Various people were saying at the beginning that there was perhaps a feeling that anything went at the beginning, so Zoom and so on were all seem to be okay. But actually, what's become clear is that people, if you're in the NHS, you're having to use the NHS platforms. So certainly Attend Anywhere, Near Me, and to some extent Microsoft Teams, perhaps in some people. There's clearly variation across services. And I know one of the problems is that lots of people, it's taken quite a long time for people to get set up on Attend Anywhere, because of course the entire of a health board or trust are trying to get onto that. But you need to check what your health board will or trust, NHS trust, will allow. Again, practicalities here. You need to make sure that your client or patient has a reasonably stable, decent, speeded internet, and if not, it's not going to work. Again, the point has been made here, practice, practice, practice using the technology. Martin emphasized it. And again, when I'm hearing from colleagues who are doing this, this is the thing that people have emphasized very strongly. Don't just try and jump into this. You've got to practice. You've got to work out how you're going to actually do it and feel confident doing it. And know how it works so that you can assist your client in how they're operating it. There's a nice quote from the Nicholas Priestley said. He said, "It's nearly always the case that the client will either see you before they can hear you, or that they can hear you but can't see, or you can't hear them." So you've got to be confident about how to tell the client how to turn on, adjust their microphone. Now, again, as he said, that's okay, it's self-evident. But if you bumble, and I think Martin was saying this, if you bumble, the lack of expertise becomes manifest, and it's not easily recovered for the serious business, and the risk of disengagement increases. So again, just an emphasis on get to know the technology that you're going to use and be practiced. Work out how you're going to administer the tests. And of course, one of the critical things, and it's come up, I've seen on the chat there a little bit, probably one of the most critical things is the administration of visual tests. And I'll come back to that in a little while. Next slide, please. So, okay, the client. So not all clients are appropriate for teleassessment. And again, it struck me that, and somebody made a comment, I think, that, as waiting lists potentially accumulate, as people were talking about, in a sense, that services are on hold. Well, of course, all that means is that the waiting lists are potentially accumulated, and there still will be a period where perhaps people are doing more, but the pressure to get the waiting list down will be there. And I guess it seems important to make sure that we're being very careful about only doing those assessments in situations which we judge them to be appropriate for that individual person. So the client needs to be able to manage the technology independently, or have someone there to support them. But again, obviously, ideally, somebody else shouldn't be present during the actual administration of tests, except in the case of children or adults with significant cognitive impairment or other need. It's important to check the communication skills of the client beforehand, perhaps with the referrer. And then again, a really important point that's been made by several people feeding back to me is that consider a phone interview initially. So most people would have some sort of phone contact initially, in which you can do perhaps your clinical history, take the cover of the background, but also you're checking, in doing that, you're checking on the communication ability of the client, and perhaps judging and making a judgment about whether the video assessment is going to be feasible. And similarly, it's part of that preparation, and Martin mentioned it and others have mentioned it, an email or letter to the person explaining in detail how things are going to work, including the importance of avoiding interruptions, and what preparation is needed on the part of the client. For example, having a pen and paper available by the computer. So that preparation is really important. Preparation of yourself and preparation of the client. There's a suggestion of using a specific consent form, and certainly on the DON guidance document, there's an example, a sample consent form that you could draw upon. Okay, next please. The setting, and again, Martin mentioned the critical thing is thinking carefully about the setting. So your aim is to mimic the usual clinic conditions as far as possible. So the simplest thing is to just think about your background. Obviously, some on things like some services you can use. You can fade your background, you can blur the background, or just think about the having a plain wall or a curtain. Steve Meldrum made an important suggestion to me the other day, which was just wear your name badge. Again, it's there. We would always wear a name badge in a normal clinic and hospital environment. So if you've got your badge there, again, it's helpful for the person. Interruptions there. That's my watch. Just I don't know if you heard that. My watch was picking up on something I was saying and thinking it was trying to be helpful. So think about the background, create that clinic ambience. Again, frame your head and shoulders in view. Perhaps consider a lapel microphone or a headset. Again, that can often help to reduce distracting background noise to some extent. And again, be organized. Again, Martin mentioned this. So have the files you're going to use. I mean, we'd always want to be organized in doing an assessment anyway, but it's particularly important if you can't, it's not really good to get up and wander across to a drawer or find something. Maybe you can get away with doing that in a clinic office. But when you're disappearing off screen and the person doesn't know where you're going, that's more difficult. So have things available, have them in order, have them well filed, have your stopwatch there. Just be more organized perhaps than you might ordinarily be. Okay, next please. Okay, so thinking about administration of psychometric measures. So it's been mentioned again that neither the client nor the clinician should record the assessment. And this is primarily focused on test security. And this is something that the test publishers are very clear about in allowing people to use tests through neuropsychology, through teleconferencing, is that shouldn't be recording. It may be tempting as a clinician to say, well, actually, it's quite handy. I can record the session and then that will be helpful for a later record. That's not actually allowed. Karen Taugert suggested in her feedback to start with some warm-up tasks. Actually, something, a couple of tasks which are the sort of shorter ones, or just something that gives you the opportunity to ensure that you and the client are comfortable, that the audio is working well before you move on to the more demanding tasks. Don't just dive into list learning or a story recall task. Steve Meldrum made a really nice point. It takes a while to get the rhythm right. Okay, so we know that however good the connection is on a remote connection, there's often just a bit of a delay, and we all know that it can disrupt that sort of that flow of interaction. So allowing the pause to allow the client to finish can be really important, and it's probably better to avoid sort of encouraging mms during the interaction, because actually, again, if there's a slight delay, what you see as just a sort of an encouraging delay maybe seen as a cue to an interruption, and it just disrupts the flow. So it's better just to pause and learn, but that takes a while. And again, it's part of the practice. Okay, so thinking about tests, wherever possible, use specific testing tools that have been shown to have comparability when administered remotely as with in-person assessment, wherever possible. And of course, we know that actually a lot of times that may not be possible. So think carefully about whether an assessment can be conducted in a way that's directly comparable with a face-to-face administration. For a lot of things that we do, actually they can. But increasingly, there are a number of studies that have tried to look at the comparability. Next slide, please. So on this one, I've taken, again, helpful slides from Rennie Stolwick and Jodie Chapman's work here. So what we see actually is there is quite a lot of evidence for the comparability or the reliability of tests done in a remote context compared to tests done face-to-face. Now, again, the caveat I mentioned right at the beginning there is a lot of this is done not in a sort of in-person home, but more in a sort of remote clinic type of environment. So we have to interpret cautiously. But I'm not going to go through all of these tests in detail, but just wanted to illustrate, and again, these slides will be available for you. But if we look at screening tools, so Mocha, MMSC, CamCog, RUDAS, some of the batteries, the WASI, the R-bands, again, I think Helen Newby mentioned earlier about administering the R-bands, the NIH Toolbox Cognitive Battery. Going on, Ingram, next slide, please. So tests of pre-morbid ability, so the NART, which are the top. So some of this work is in a paper, so some work that Jodie Chapman has done recently. I think that's in a paper that's still under review. So they've kindly, Rani and Jodie have kindly shared that information. Things like clock drawing, matrix reasoning, verbal memory index, VOSC, and block design, all been, again, all the ones I'm listing here are involving studies where broad comparability has been examined. Next slide, please, Ingram. One back. So again, one forward, that one. So in terms of learning and memory, so a range of verbal, but also visual memory tasks have also been done. Again, I'll come back to that in a minute. Some executive tasks and psychomotor. Again, of course, something like the groove pegboard, that can only be done when you've actually got a groove pegboard in a remote. So that doesn't apply to most of what we're thinking about just now. Okay, next slide. So in the work of Jodie Chapman in this work, you can see here what they've looked at is the consistency between remote and in-person sort of. Some of the consistencies are good, well, excellent, good, and fair. So plenty of the evidence that these things can be done in this sort of remote type of context. Okay, next, please. So a quick note about the administration of visual tests. So if you look at what Pearson is saying on their guidance, so the critical thing is we're not supposed to scan test materials and then present them from your computer. That may feel frustrating because actually, obviously, that would be a good way because you could share the screen. Now, a number of tasks are becoming available via the Q Global system, but to be honest, not a lot of the ones that we would use routinely certainly in adult clinical neuropsychology are there yet. Hopefully, they will get there. Obviously, in things like Q Global, what you've got is manuals and stimuli that can be presented via your computer screen, but they're not there yet. So we are having to find ways to present them. And what Pearson is saying is be careful about how you set it up such that you are getting the size right. So in other words, you don't want to make it so that it's very small on the client's screen. And also interestingly, there's guidance that if somebody happens to have a very large computer screen at home, you don't want something to be enormous in front of that person. So you think carefully about what sort of distance that you are to your computer and you're presenting to your camera, and similarly what distance the client is from their computer screen, and how big that computer screen is. There's a suggestion that an iPad size is probably the minimum size. So obviously you're not wanting to present people visual stimuli on things like phone screens and so on. So avoid very small or very large screen. So the key issues really are being clear how you're going to present the stimuli so that they're correct size on the client screen. Holding things up is tricky. So I know I've seen sometimes people are sort of, in instance, trying to prop things. But again, plan that in advance and practice so that you can present it in a way that's consistent. Some people maybe get used to being able to hold things in a particular way that's consistent, but you need to, again, another reason why you would need to be very practiced if that's what you're going to do. The other option is to have a second camera, again, that you link so that you can then present it and you know exactly what size you're showing. So again, I think when we first started looking into this, there was an assumption that, well, visual tests are just out because they're too difficult to do. Actually, I think as people have got used to it, I'm certainly hearing feedback that it is feasible. You just have to think carefully, prepare well, but it's not always going to work depending on how you're interacting with the client. Okay, next one, please. Just a quick note, I've been focusing here on assessment because I guess technically doing neuropsychological assessment is one of the bigger challenges. But of course, a lot of people, neuropsychology is also neuropsychological rehabilitation. And just to note that actually there's some really nice BPS guidance on doing therapy via video. This is not specific to neurological populations, of course, more generally, but that guidance is all, again, very sensible, practical, and helpful. And of course, it's going to be important that we make similar adaptations in the way that we adapt in-person therapy for people with cognitive impairment. Well, the same sorts of adaptations are going to apply when you're trying to do something remotely via video. Next slide, please. Again, in terms of, say, cognitive rehabilitation, Rennie Stolwick's group, Diana Wong in Australia, have been doing some really nice work, some really good preliminary evidence that cognitive rehabilitation interventions can be delivered using telehealth approach. And certainly, again, a few people have said on the chat, and I've heard a few people commenting that there are potential benefits of delivering treatment and intervention in the home environment, even when you're remotely. And in fact, even because you're remote, sometimes you're getting an insight into how the person is being in the environment. Susanna Watson, who works in the paediatric brain injury rehabilitation team in Cambridge, was commenting that she felt that actually with some families that the interactions that you were picking up on when you were remote and the client and the child were at home was actually rather useful in providing useful information. So I think there are opportunities there, and I think maybe, as we said, going forward, some people will continue to offer this sort of service because of its beneficial in some situations. And again, when it comes to rehabilitation sessions, then again, opportunities for recording may have advantages for the client to facilitate review and enhancement of the treatment interventions. Okay, next slide, please. Yeah, just a note, I mentioned Karen Taugood. So Karen is actually is going to run an audit of the use of tele in neuropsychology. So I said I would mention her work, and if anyone is interested in conducting an audit in their service and linking in with Karen, and perhaps we could get a sort of cross trust audit going, that would be really good. So Karen's email address is there. So she's put together an audit form. So that's very well advanced. So worth contacting her. Okay, next one. So obviously, as we said, I've been talking primarily about sort of adults, I guess, working with adults in doing neuropsychological assessment or neuropsychological rehabilitation. But there are a number of specific issues to do with children, people with intellectual disability, and older adults. So I'm going to pass over to Sophie and to Rebecca.
So I'm going to talk about some of the populations where we might require some additional consideration, specifically with respect to teleneuropsychology. So whilst my background is with children, we're going to cover some issues that are relevant to adults also with specific needs, which should be relevant to all of you. And Rebecca is going to talk specifically about considerations for older people. So we've already talked about potential limitations and opportunities, and I think we probably all agree that no clinical data is better than bad data. We know there are some things that we can't do and that we shouldn't do, but with this in mind, there may be times when we can do something helpful. And we might need to consider this, as John says, on a case-by-case basis, but also alongside the specific needs of the population that we work with, applying our own experience, judgment, and common sense. If I can have the first slide, Ingram. So some of the populations that come to mind that we are going to have to be specifically mindful of are young children. We often have to work very hard to engage young children as it is. They're not inclined to be still. They can be suspicious of new situations and strangers, let alone somebody appearing on a screen in their living room. And we need to engage in quite a dynamic way. And when you're just a little face and voice on a screen, you have much less control, and this is far more difficult. I'm very aware that I'm not Mr. Tumble, and I'm unlikely to ever be that entertaining to engage a young child. for any long period of time. But this said, I think all children are now becoming increasingly familiar with talking to families, such as grandparents, during this time this way. And some researchers I know have reported a reasonable degree of success in engaging, assessing young children. But we need to be realistic and at very least heavily reliant on a third party. Older children, I think, are more familiar with and indeed better at this than we are. And I don't tend to consider this a problem whatsoever unless they have specific difficulties, which I will discuss, but we do need to consider adult support and consent in the process. Also, if you have an engaged older child or even an adult who is a parent, family homes can be very busy. Martin's already made this point. They can be noisy, so we need to be really explicit up front in preparation to manage this, which I'm going to come on to. So if we think about children and adults with specific difficulties, naturally for those with learning difficulties, we might be concerned about how someone with impaired ability to comprehend, weigh, retain information and communicate might make sense of this medium and understand the corresponding risks and limitations we've already spoken about. For some, I think it's just not going to be possible, particularly if there are profound disabilities, but there may be the opportunity to work through someone else in their system, or they're going to need a lot of upfront and third-party support, which I'm going to come on to. For those who struggle to maintain attention, our lack of physical presence, I think, makes us really quite powerless to keep them engaged in the same way. And coupled with the fact that we can't control the environmental distractions, this could be additionally very challenging. Similarly, those with social communication disorders, this different media of interaction is likely to be more difficult and something they may struggle with. Having said that, I've had some feedback that some people with autistic spectrum disorders actually prefer this. And certainly I can think of young people like that who form most of their relationships and in fact their social world is online. So that makes quite a lot of sense to me. However, for someone who suffers significant mental health problems, particularly anxiety, this new medium may be quite challenging for them. We know that people with social anxiety struggle to use the phone, and some may flatly refuse to engage in this way. And I think for those who have low self-esteem or self-image, seeing your own image staring back at you is very disconcerting. We're not used to seeing our faces in motion. I'm not enjoying it, and some people won't do it, which I think is understandable. For others, I think staying in the safety of your own home and not coming to hospital may actually provoke less anxiety and may be an opportunity for us to engage with some of these patients. Another issue I think is managing distress, and this came up in the US INS webinar. It can be very difficult if someone becomes distressed and you're on the other side of a screen and not physically there to help them and to manage the fallout from that. So with vulnerable patients, I think it's going to be quite important to consider who else is there supporting them at the other end and what to do in that scenario. And also to think really quite carefully about opening up issues in complex families when they're all trapped in a house together. There are some things that are probably better untouched for now. For those with sensory impairment, this is going to require additional adaptations, as indeed is the case for face-to-face assessment, but perhaps more so and may be prohibitive for some clients. So naturally, we might be concerned about how older adults might adapt to the use of technology. Some of my physio colleagues were telling me that some of their older people are actually quite enjoying intervention this way and avoiding a hospital trip. But I've noted in the chat box a lot of people that work with this population saying they're really not keen to take up this at all. And I'll leave Rebecca to talk about that because she has much more experience in this area. If I can have the next slide, please, Ingram. So having accepted that we might need to think differently about some of these populations, I think these are some of the things we need to specifically consider. We need to consider how able they are to consent, to understand the caveats and risks and the governance issues, and to engage with technology. And how this affects what we're measuring. I think there is potential for much greater risk with construct validity if you have someone who is much less able to engage. And these factors together govern the utility of what we can offer, how sensible it is to proceed, I think, and will also affect the patient experience. So Being mindful of the patient experience, I found the presentation by Lana Harder at the recent INS webinar really helpful. So this is something that's unpublished. The link is still live, I think, on the INS website, but it's at the end and you have to listen all the way through to get there. So I thought it might be helpful to just summarize some of the things that she talked about. So this was a research study, and they practiced in a different way in that they relied on sending materials out to the patients and families, which we're not necessarily recommending. So that enabled them to do a broader range of tests. They did the WISC, vocabulary and digit span, the single digit modalities test, the BMI, the CVLT, and DKEF's verbal fluency and colour word interference. And with their 58 young people, they gave both video testing and in-person face-to-face testing, and they counterbalanced this, so half did each first. And what they found, which fits with what John's been telling us, is that there was no real significant difference between the test scores for face-to-face versus video link assessment, but also that the parents and the children, they rated feeling comfortable with the technology and equipment. They rated, most of them rated finding the video link assessment acceptable, or very acceptable, and that they were satisfied with the video testing. And when asked whether they would prefer video to face-to-face, a very large proportion said that they were happy with either. Next slide, please, Ingram. So with these things in mind, I think if we reflect upon how we can adapt our process, and Martin has already alluded to this, those that have done a lot of work on this in the US and Australia really assert the importance of preparation. I'm quite a fan of pre-appointment triage and telephone calls anyway, not just for waiting list management and ensuring our service is actually what somebody needs, but it's an opportunity for a family to share useful information that you might need to know, to discuss any anxieties or complexities that might affect their engagement and any modifications you may need to make. And in the case of children and families, it sometimes gives a parent an opportunity to talk to you about things they might not want to talk about in front of the child. It isn't nice for a child to hear a list of all the ways they're failing at the beginning of an assessment. So obviously with adults and older children, you need to ensure everybody's involved in these conversations. But my point is, I think there is value in this preparation anyway, but in teleneuropsychology, it becomes much more important because it provides a bridge to this new form of engagement. So this pre-assessment phase, it gives you an opportunity, firstly, to think about the referral question and whether or not you actually think you can help. You may know this from the referral, you may have already decided this, or it may require a conversation. And I can imagine many different scenarios. You may have someone with a severe ABI who's telling you that they're suffering processing speed and memory deficits. You can't test the former, but you probably can test the latter. But either way, it's probably reasonable to assume that they genuinely are having these difficulties and therefore would benefit from some strategies to help with this in the meantime, regardless of whether or not you do the testing. Similarly, those that are coming back for monitoring progress, do they really need a whole battery of testing again? Could you screen them? Could you hear their perspective on what's troubling them and the cognitive difficulties that they're struggling with, and give them some strategies to intervene? Intervention and therapy online isn't a new thing. Lots of people do this remotely already. In contrast, diagnostic assessments, for example, dementia or dyslexia, where you are going to make a decision that has a lifelong impact, maybe final reports in legal cases, are situations where you need to be much more wary because it's not a holding position, you're giving a much more affirmative decision. The pre-assessment is also an opportunity to discuss the process. So the caveats and risks that we've all talked about. In my experience, families are much less concerned about governance and risks to information transfer than we are, and are actually much keener just to get on and receive some help. Also an opportunity to talk about what you expect from them in keeping a quiet environment and ensuring they've got the technology and are happy using this. But also an opportunity to discuss any particular concerns the family or the client might have. I know that some of my colleagues in CAMS have been worried about children who've experienced bullying, cyberbullying via the internet, social media, and that they may be reluctant to engage in this way, or any other anxieties. And this is an opportunity to talk about this, to see whether it's going to be prohibitive or whether or not you can simply make some modifications to help them access. So I think this pre-assessment conversation, it gives you the opportunity to decide, is this going to be helpful? Do you think you can do something that is useful and valid? Is it what they want? And what adaptations can you make? The assessment, I'm going to just gloss over very briefly because a lot of this is already covered. The point has already been made that it's really important to make sure you're prepared and have your technology and tests organised. Engagement is something our Australian colleagues have talked about quite a lot and is really emphasised by them, and something that we need to work on, particularly in terms of how animated we are. I think it's easy to appear desperately dull over a video link, and I've witnessed this even with primary school teachers who are normally very good at this, becoming completely expressionless and monotone, probably because it feels uncomfortable, and also you lose the dynamics of that social interaction. This is a skill that I think really needs to take practice, So the biggest difference, and John mentioned this earlier, for these populations is the role of a third-party supporter. And you'll need to negotiate, I think, the boundaries of what is and isn't required. For those that are relatively able, this would be light touch. They can simply be there to check technology and to consent with those under 16. But for those who are really impaired, they might need to be quite involved and facilitatory, or for very young children. But you'll then need to explain the boundaries of what they can and cannot help with quite clearly beforehand, as you would in an assessment if you had a carer or a parent present. Finally, once you've conducted your assessment, and let's face it, we don't always know how our assessments are going to turn out, and this is the case with many of my face-to-face assessment with complex clients. Until you've tried, you don't quite know what data you're going to get, but as a skilled clinician, we're able to think about how we interpret data. We know if someone was cleaning the windows while someone was doing a verbal memory test, that our scores might not be very valid. And we need to think about how we communicate this in a way that is clear to others. And this might involve what the range of explanations are for the data you have, for the scores you have, and what the caveats were for your assessment, how you've undertaken the assessment, and any corresponding limitations. And I don't think this is new in many ways. Those of us who work with complex populations, I think, are very familiar and skilled with making a whole host of adaptations to allow patients to access testing that often, quite frankly, do violate standardisation. I once tested a 4-year-old child on a ward in a tiny Wendy house in a playroom. Well, she was in it, I was sort of on my hands and knees, half in it, half out, because she made it quite clear that if she was going to do anything for me, it was going to be on her terms, and the team really wanted to know how she was going to manage. She was about to go back to school when she was discharged and engaging with rehab. And it really wasn't a very standardised experience, but I decided I would learn something from it. And sometimes you need to see what data you get from it to understand this. In this case, this child did very well. She got scores in the average or above average range. So I'm able to include that if she can do this while serving ice creams and pretend soup through a hatch, then her cognitive abilities are relatively intact, which gives us courage in her returning to school and engaging in rehab. Obviously, if she hadn't done as well, then there would be a range of explanations for this. And I don't mean to be flippant, and I know this isn't exactly comparable, but I tell this story as an example of how we make judgments each day, and that we're all qualified and experienced in doing this and making these judgments, or we are supervised by someone who is. And we have the skills and the knowledge to think about how we can adapt and what is and isn't sensible, I think. Obviously, if there is an alternative and you can do this face-to-face in the near future, then you would do that instead, but maybe there isn't going to be that alternative. So if I can have my last slide, please, Ingram. So I think my final thoughts are, what are the risks of going ahead and what are the risks of doing nothing? And that might depend how long we're in this situation for. And that we need to balance between the clinical need and the best interest of the family in accessing patient care versus validity and our own anxieties about doing something in a way that's quite different to us. And we need to recognise that, I think. There could be some opportunities to improve patient care, reach those that Candice has already mentioned, reach those that perhaps cannot be reached, involve others from the wider system in the assessment that we might not have been able to do, maybe a teacher, maybe someone from residential care home, we could dial them into an assessment, or supervision. I could dial Ingram into a session because he has specialist expertise in a particular case while he's in Bristol and I'm in Nottingham. So I think this does offer quite a lot of opportunities for us, acknowledging, of course, the caveats and the risks that we are all aware of. So I think, what I want to say was really that we are more than just our tests. We're experienced clinicians with much broader skills in assessment, formulation, and intervention, and there are many ways that we can help assess or intervene without necessarily doing as many or even any standardized tests sometimes. And I think this is going to stretch our clinical skills, because we can't rely on getting everybody through the standard battery and giving them the scores at the end of it. But lots of people do therapy and interventions remotely, so this isn't new in many ways. So yeah, I guess my thoughts are there's some things we clearly cannot do yet, but this may evolve as more tests become available for this medium. We need to be careful and understand the limitations, but there may be some opportunities for us to practice in a way that is really, really quite helpful. So that's all I wanted to say. I'm going to hand over to Rebecca, who's going to pick up considerations for older people.
Lovely, thank you, Sophie. And thank you to the DON for a nod towards older people. And I suppose starting by thinking, do we need to consider older people as anything other than people who are a bit older? And so what's special? Why do we need to have a particular thought around this? So I've done pretty much the same as Sophie, except I've called my before, during and after, because I'm not quite as eloquent. So we've had quite a bit of conversation already, and on the INS webinar as well, about what you need to do in the run up to it. And so there was some very nice piece of advice about make sure that your patient has the right piece of equipment and the right broadband. So I typically would like to arrange my appointments with patients by phoning them up, because I find they have a much smaller DNA rate after that. So that initial engagement by telephone is something that I would do typically. But in this case, it's even more important. And I thought I'd just give an example of a conversation I had with a chap recently, just trying to establish that piece of information. Have you got a laptop? Have you got a webcam? And are you on the internet? And that took, as you can see from the arrow, that took 20 minutes to come up with the answers for that. During which time he became quite distressed, he became quite anxious about whether or not he should give out his details to me, because obviously he's not met me before. So there's a lot of information advising older adults what they should and shouldn't do in order to not be scammed. And then here I come along, a weird person with a weird surname, asking them to do something entirely peculiar. And so I think what we're finding with older people is that actually we're tapping into societal commentaries as well. So as much as we consider the neuropsychological issues that are at play, and whether we can use a test and whether we can breach copyright and all those kinds of things, we do need to default back to our kind of psychological training as well, and to remember that these people are people. And I like to think about delivering psychology within, so I'm compassion focused therapy trained, so I try to deliver neuropsychology within a kind of CFT framework, and think about, so what actually is being triggered in this situation? And is it that one of the things that could be happening for older people more than for younger people in this situation is that we're replaying those societal messages that older people are actually quite out of touch, they're out of date, and they're quite useless. And all I'm doing is adding extra shame to this person's narrative. So how do I get around that? That's one of the things we need to think about. And particularly in this situation with COVID, the reason that we're thinking about offering teleneuropsychology is because of COVID, not out of any other choice. And so it's just bringing to the forefront of people's minds, well, my son would normally help me with this, and I'm just so very isolated, and I can't do this, and I'm helpless, and I'm hopeless. And so I think what's helpful is then to have this, you know, as we probably would anyway, have as a driving force a sense of collaboration, and have this as, you know, that externalizing narrative of sort of saying, this is really difficult for all of us, isn't it? This is a really bizarre situation that we're in. And starting that conversation, you know, it's an informed consent conversation, isn't it? This is what we can do. This is what we can't do. These are some of the risks and the benefits. And is this the right thing for you in this moment in time? So then moving on a little bit into the during. And I suddenly found when I was writing this up that everything began with the letter P. So then I decided to go with the letter P, which was very exciting. I don't know why. So the planning. So one of the things that I find with working with older adults is a lot of them are on a number of medications. And so polypharmacy will quite often have with it dry mouth as a side effect. And so we're quite used to having glasses of water and providing that within an assessment setting. So maybe actually making that very explicit, that one of the things you might like to have with you when you have your assessment with me is a glass of water with you, because we might be having quite a bit of conversation. And what I've started to do is to send out quite a specific set of, these are the tips that might help you. So this is where the on button is, this is where this is. These are the sorts of things that might be helpful. So what you can see in your screen is the same as what I can see face to face. So if you can't see anything over there, then nor can I, so don't worry. So lots more about the planning and the run up to what we're trying to do. Positioning, and I know somebody in the chat has been asking about rehab as well. And I don't think really today we're particularly focusing on rehab, we're focusing more on the assessment, but that positioning of, right, Mrs. So-and-so, I can see the top of your head. Yeah, no, move the laptop screen down a bit. No, the other way. No, not that way. And really that importance of actually knowing where the person is sitting. And also, you know, what I found yesterday with a couple that I was working with, the wife who is the non-patient but was incredibly bored in lockdown, so really wanted to join the assessment session. She was in the background gesticulating in the way that somebody would in a clinic room. But obviously when you're doing it on the screen, then the patient can also see what's happening behind them. So those subtleties that normally maybe a spouse would keep from their partner, they are now being seen. So positioning, things like that. And then P breaks. So P is for prostate and P is for pelvic floor. So we know that with our population, people need to use the toilet more regularly. But within this setting, I feel that they really need to have permission to do that. So the permission to say, we can take a break at any point. And because I can't pick up on body language as easily as I could do if I was in clinic, I'm probably not going to be able to spot whether or not the person wants to and needs to have a break and use the bathroom. And I think with the older generation, and obviously I'm generalising, there's going to be exceptions to the rule, but with the older generation, that concern about breaking the computer or breaking the internet or some kind of thing like that is very concerning. And so just to have that conversation about, there's nothing you can do that's going to make it go wrong. It's going to be okay. And if we lose each other, that's fine. So again, starting the session, that took 20 minutes as well. So when I started to think about, would this be something that we would want to do long-term post-COVID? So if there was an option of an alternative, by the time I've had that conversation at the beginning, before we've started, had the 20-minute conversation at the beginning of starting to make sure the microphones are working, the internet's working, all the rest of it, that's almost 3/4 of an hour of clinical time. Is that good value for money for the NHS? And I'm not sure it is. So I don't know that I would advocate for it long term, but maybe for some people it would be good. And then P being for patience and panic. Again, kind of thinking about the CFT framework, we know that we've got the option of being in threat, and if we come out of threat, we could go into drive, or we could come down into soothing. I very much feel that I'm being pushed into my drive system a lot more with the tele-neuropsychology, that sense of, come on, we can do it, let's get it done, go on, you know, no, press that button a bit better, no, it's okay, it's going to be okay. And I think just to really reflect back on, am I panicking in this situation? Is there anything more that I need to be doing? And the patience that you need for, in minute detail, being able to explain where the enter key is, or where the up button is, or how to connect to what a cursor is, what the mouse is. It just takes an awful lot more time. And as I say, you know, not everybody who's older is going to have that experience, but that's been my experience of working with older people. So then thinking about other people in the room and how you manage that situation. I tend to use a bit of light-hearted humour most of the time for most of the things. So some of the things that I would say to people are, well, Mrs. So-and-so, you've got a few options now. We've moved out of the interviews situation. It's been really helpful to have your feedback. Now we're going to move into the assessment phase. So there's a couple of choices. You could either leave the room, or if you happen to have some sellotape handy, you could at this point stick it over your mouth. not sure which you're going to go for, you know, and depending on the rapport that you've built up with people, to make this a little bit lighter, because it's incredibly heavy and worrying for people. Then moving into the after column, so what is actually available after all this? I know a number of people have been talking about memory clinics. The majority of memory clinics that I know about around the country have shut down for the time being. And so along with that, there's also not the post-diagnostic support that there would be typically. There aren't the dementia cafes, there aren't the kinds of community pickup that there would be. There are some that are offering community dementia cafes on Zoom. Again, it's very dependent on somebody being able to use IT. So what actually are we able to do? So if you identify a need, have you got time within this new period of time to mop up extra needs that you wouldn't normally offer? But actually, if you're starting that process and starting an assessment, what are you going to do about it afterwards? There's no point in having a diagnosis unless you do something about it. And just the final point always is this has to be timely. So is this the right time in your life for you to have this assessment? And if not, that's fine. And how do I enable you to say to me, no, I don't want to have this assessment, or I've got halfway through and I feel completely overwhelmed with this experience that I want to stop? How do I enable you to leave with dignity and say, okay, that's fine, we won't bother to continue this assessment, but we will provide something. So I don't think there's a huge amount that's different, but I think there are a few things that we do need to think about just in terms of our social narrative and in order to preserve somebody's dignity and not to re-shame them when you're working with older people. Okay, thank you very much, Ingram.
Thank you, Rebecca. Thank you very much. Thank you to John, to Martin, to Sophie, and to you, Rebecca, for such a tremendous effort. And John, it's really helpful to have that practical overview, Martin setting the scene, and Sophie and Rebecca reminding us of some of the very real practical considerations for various populations. I'm going to follow Rebecca's lead, and despite the time, propose that we have a short pee break, whether that's Prosecco or having a pee. And if we come back in, could we say 3 or 4 minutes, just to give our panelists a bit of a break and allow me to solve some of the technical issues I'm facing in the background without disrupting us any further. We'll still aim to finish at 4 o'clock. But I suggest we have some discussion on the back of this around teleneuropsychology, possibly slightly abbreviated, and leave some time at the end for final questions. So if we have a 3-4 minute break now, so if you can come back at 15:37, that'd be fantastic. It gives me time to put the kettle on. Thank you very much.
Any views, advice regarding medical, legal, neuropsychological assessment? This person's postponing at the moment, but wondering about going forward. I think it's a very interesting question. I think that my view, the context in which the assessment takes place has a sort of influence over a decision, but the validity of the assessment is the validity of the assessment, irrespective of the context potentially in which it's being undertaken. There are more things to think about potentially in a medical legal assessment, but I think we have to come to a professional consensus view about whether tele-administration of a tool or another is valid or not. That's the real question. If we can establish that it is, we think, valid or valid enough conceptually, then it becomes a question of, in this context, is it enough to answer the question I'm being asked? So I think medical legal, we are under more scrutiny, but I don't think the issues are materially any different. Just different.
I have a comment on that also, which is similar, in that I think it depends on the question being asked. I do medical legal assessments with children. Often you're providing an interim report upon which a final decision isn't being made. Sometimes it's to recommend something else that's going to happen in the process. In that case, I think you can provide something, and some people are providing something, but only within the parameters of the test that you can use and the information that you can reliably gather, and also within the parameters of the extent of the disability and the sort of information you're going to need. With profoundly disabled young people, you don't actually need any standardized tests at all. So I think there are some things you can do, but anything that requires very comprehensive, careful assessment upon which a final decision needs to be made, we're all very cautious about at the moment.
So my general, I mean, I do medical legal too. My general position on this is that you're constrained. So the tools you can use potentially are constrained. That limits some of the opinions, but not all of the opinions that you could give. And you're more likely to have qualified opinions that defer some things to the future. But I see that as still potentially valuable. One of the concerns I have is that medical legal is a vehicle sometimes to help people. And if we postpone giving any opinions when actually we could give those opinions, we are postponing someone's access to help, which is potentially not necessary and a negative outcome. And that's different from questions that might be around someone's liberty to live where they want to, or the size of a settlement that's determining by very subtle difficulties. So that's, I guess, is the same point you're making. You know, there are some things you could probably do, and there are some things where you probably want to be more cautious, but the context itself isn't necessarily the determining factor, although the scrutiny will be higher. The reports that I've, I mean, I've only done a few, to be fair, and what I've done in those is talked about all of the threats and limitations and just being very clear about what I'm confident about, what I'm less confident about, and what's being deferred and why. I think just being as open as possible is the way to do it.
Is there also a role for sharing some of that responsibility with the legal team as well?
Yeah, absolutely. It's a dialogue that you have. Yeah. We're all trying to essentially address the same problems, aren't we? And they have the same limitations and constraints. And I guess, it's about everyone understanding what's possible, what's not, what's reasonable, what's not, what the limitations might be, which in essence is the same as it's always been. That's always been what we've done. We've just got more things to talk about now than we had before.
Julia Cook has asked about cognitive assessments for the diagnosis of dementia. There's a paper that's quite relevant to that. I can't type into the question and answer box, I don't think.
I can type, Rebecca. Just tell me what I can type that. We can just answer it live if you want to pick up on it.
Yeah, if you can just say, has she seen the Castanho paper, which is a Portuguese Castanho.
Sorry, my spelling's not as quick as yours. My typing's not as quick.
CAS.
Yeah.
TAN.
Yeah.
HO.
It's
a 2017 paper that answers that question, really.
So that's gone out. We're obviously talking to our audience as well, Rebecca. So they've all heard that, and they've heard the spelling. So they're all. So no, they're all there. We've got a few. Sophie, are you happy to pick up these questions? There's one about epilepsy surgery, which I think is an interesting one. I don't know if I can just address.
Do you want to take that one, Ingrid? I'm thinking we probably might not get through all of these questions in the time we've got, but do you want to take that one?
I can take that one. So at the moment in the NHS, so this is from Sarah Clark. I mean, the answer, I suppose, is that a lot of elective surgery has been postponed, and so a lot of the necessity for us to undertake tests in that kind of context has been correspondingly postponed. But I suspect that this stuff will come back to us, won't it? And there will be an urgency and a bit of pressure to undertake assessments that inform someone's care. I think, as Martin's pointing out, some of these considerations are universal, aren't they? That we don't want to hold up what is otherwise resolution or treatment. And while we might have concerns about the validity of an assessment that is constrained, I think we have to balance out, what are arguably valid constraints with also valid and desired outcomes. And I wouldn't want to stand in the way of someone having a definitive cure, which is what it is in many cases for their epilepsy, because I'm concerned about the validity of an assessment. But there will be attendant risks due to those constraints. But I don't think there are any absolute barriers. I suppose that's enough, I think, on that question for me.
Thank you, Ingrid. The next question from Catherine is about PPE and the anxiety this causes, and also the validity. I think Martin and John have already talked about this a little bit. One of you want to take that one?
Well, I think so. So this is the Catherine Smith-Mays question.
Yes.
I mean, she highlights all of the difficulties and then asks a question to which I'm not sure anyone has an answer. Which is, I mean, she's painting quite an extreme picture, which I think is a really challenging one. And what are the impacts of that scenario on assessment validity? I think it falls into the same sort of general rubric that we've all been highlighting, which is we've got to look at this as a case-by-case basis. I mean, the person asking the question has highlighted lots of things that are obvious threats to validity, and the question might be, what is it you could actually address as a question reasonably, and how might you do that? And ticking things off in an individual case that's being described here, you're probably left with not very many things that you could reasonably do. And so, you know, the answer might be it just isn't a valid approach for this particular case, and you might have to think slightly differently about what's helpful. I don't know if anyone else has a different view, but that's essentially what I came to.
I think that captures it nicely. The next question from, oh, they jump, an anonymous attendee who said our guidelines are very helpful. Thank you for that. We rushed to get those out. But this is about validity. I wonder if John might be able to comment on that.
So this one's actually,
oh, go on, Martin.
Sorry, I didn't mean to interrupt you, John.
No.
I'm saying it's about consent, the question.
Okay.
So I think
consent to be valid, yes.
Yeah, so I think that it touches on some very interesting points. So the consent form in the DON guidelines is about the consent to a tele-administration. It's not a consent to the assessment that you're doing. So just like you would in any other context, you consent someone for the specifics of your assessment. So that consent form was about the modality, because that's an additional thing that we're adding in that people need to understand over and above a consent that you might normally undertake. And I think what's interesting about the second part of the question is I don't think we can consent people to things that we think are not valid. So I don't think we would do it if we didn't think it's valid. I think what you end up doing is having a conversation with somebody that says, through this modality, these things are valid, these things are potentially less valid, but you wouldn't say, and these things are not valid, would you agree to do them? So we just have to frame what we think. And I guess you're only going to consent somebody to interact with you in something that you think at least has the potential to answer the things that are their concern. Otherwise, you know, it's not an appropriate way to interact with them, you know, to do something that we know isn't going to be helpful or valid. So I think it's sort of two questions in one, really. But the consent form is only about the tele-administration. And the second point is, I think you have to frame what it is you're wanting to do, establish that it is valid for the question being asked, and consent them around that, and talk about any limitations to what you can and can't do, and the limitations of any validity, which is, interestingly, the same as what we would do in every assessment, actually. I think we're just re-shining a light on all the things that we've always done. We're just doing it within a slightly different context.
Next question is on executive tests. Would one of the adult neuropsychologists like to comment on this?
Yeah, I can comment.
Yeah, no, John, please do, because all I was going to say was I'm not sure we have any valid tests.
Yes.
But that's just me being cynical, so I'm not going to speak and say that.
No, I think that's, yeah, we could say that executive tests are challenging at the best of times. So if you look at the work, again, of Rennie Stolwart, George Chapman, talking about which tests have had some evidence. Now, again, the caveat is that quite a few of the things that they're presenting or referring to have actually been examined in a remote environment where maybe somebody has provided materials. So, but obviously there are things like letter fluency. So that in a recent study that showed good, and there's no reason why letter fluency shouldn't show good consistency between face-to-face and remote. Similar ways similarities, matrix reasoning. So there's more general sort of tasks if you want to consider those as executive. I know some people who sort of been doing the Stroop remotely, you know, again, and thinking not so much in terms of what's evidence, it's more thinking what can you deliver in a way that you would deliver pretty consistently. Well, there's the hailing, for example, hailing test. Obviously, you could present the Brixton as well, as long as you can manage the presentation of the visual materials. I know Steve Meldrum was saying that he'd been trying the Luria alternating hand gestures, the praxis test. And so I think there are a variety of things. There's a limited number of tasks where there's definite evidence, but there are a few. And again, the key thing is thinking, can I deliver this in a way that I would normally deliver it? And certainly for some, I think that's feasible.
That reflects the children's study as well, John, particularly tests like verbal fluency were found to be equivalent. Rebecca?
Sorry, I was just going to be sort of slightly flippant and say there's obviously an awful lot of ecological validity in whether or not somebody can manage this novel situation and problem solve. And when it goes wrong, what do they do and how do they manage it?
Yes.
You know, I think we need to be a lot more creative about saying, like you said, we're much more than our tests. Actually, our ability to observe behaviour, to notice, to formulate much more widely. And I think we're really good at doing that. But maybe don't always give ourselves enough credit for it.
If you think about the sort of things that we comment on people doing other tasks, actually being able to see people doing tasks, doing things, and how they do it is as much as what we would use in a face-to-face assessment anyway.
Sophie, there's just a few minutes left in terms of the time we've got.
There's a couple of these that I think we can answer quite quickly. Some of them are more comments and suggestions, I think.
Well, yeah, so there's some really practical things there about stands, and there's a bit of in the chat, quite a bit about Pearson. And Martin, I don't know if you've got a very brief comment, but or John, but some of the comments around what Pearson are allowing, which is obviously quite liberal, and my response to the comments in the chat have been around, well, that's a position of a commercial organisation, a publisher, but we also have a jurisdiction over what we might do professionally with that. So I suppose the point I'm making, and this is to the attendees really, is that just because Pearson will allow something or have put practical measures in place to facilitate us using the materials doesn't mean we have to use them in that way, or indeed it's legitimate to use them in that way. And I suppose we should just distinguish between what Pearson might say and what we believe is professionally justifiable, because Pearson as an organisation may sometimes say things which we think are unconscionable. You know, I'm not sure they are doing at present, but if they did, you know, we would be entirely within our professional remit to hold a different position. That's my view.
One of the questions was about posting material. I think we've covered that already, John and Martin. Do you want to make a quick comment?
Sorry,
yeah, so it's about whether posting materials to people and then getting them to send back. I mean, I saw in the chat that a few people had obviously conversations with people from Pearson saying, well, as long as you get a really clear agreement with the client that they're going to send it back, they're not going to copy it, and so on. I think more general advice is probably more that may be challenging, and if you don't want to risk test materials going out, then that's less sort of easy to do. Again, I think that has to come down to individual judgment around the task and the assessment you're trying to do.
Yeah, I think many of those things you can not need to do. So, you know, if you're savvy with Q Interactive and screen sharing, you don't need to send anybody anything. And many of the questionnaires that we might use can be administered in a sort of proctored remote way. This starts to use 2 cameras, which then gets even more confusing.
I think it's processing speed tasks people are quite stuck with.
Note that
I think there's a limitation there.
Sorry, John?
Just to note that in the new BMIPB2, there's actually an oral administration of a speed of processing test that might be worth a look.
Yeah.
Yeah, and there's the good old Passat that everyone hates. That was, you know, a fantastic processing speed measure that you can do, obviously, orally. Yeah. And there's oral trails. That was the other thing, John, I was going to say when you were talking about the executive ones.
Yeah, that's a good point. Yeah, there's an oral version of trails.
So some people have made some suggestions about glass screens, about laminating things. I think these are all things that we're going to learn about. And has anybody tried some of these tests? I think we're still in process there. And it'll be helpful if people can share their experience with each other as we go.
I had a few slides about what things might look like in future, and these are really personal reflections. I think this might be something in terms of monitoring the chat that we might need to think about extending, Catherine, because there's lots of really positive suggestions about you know, areas that we haven't covered today, or possibly people would welcome you know, some guidance and some further discussion around some areas. But the things that I've been aware of in terms of how we might rebuild things in future, and I think one of the key issues that might challenge our profession are around these issues of professional standards and how much we're pushed into a position that we don't necessarily have very much control over. I think one of the things that's happened through the use of teleneuropsychology is that we've had an opportunity, haven't we, for people to avoid the travel and inconvenience and all the attendant risks of coming into hospital. but it's also meant that the space that we've previously occupied in hospitals is less valuable as a sort of intrinsic locus of delivery of care. So it's possible for us to see patients with certain provisos from our own home. So just as they're not pulled into a hospital environment, we're not forced to go there. Now, what has struck me is that we've invested quite a lot within the NHS in these lovely spaces, waiting rooms, and we may find ourselves occupying very different spaces in future. Already the plans within our hospital in Bristol around a new wing, new outpatient facilities are being reconsidered in the light of what we might have learned through COVID. So we may find ourselves occupying very different physical spaces, or indeed not occupying them at all, and working much more from home. Now, my concern about this, I suppose, is that we might need to think about whether our neuropsychology services are delivered directly within a hospital infrastructure, or are services that could be farmed out through some agency and brought into hospital environments in a very different way that don't necessarily locate them physically or even organisationally within that environment. So it's quite possible for somebody who's thinking about, could I begin to offer neuropsychological diagnostic or treatment services to a range of hospital trusts, but not require them to be located physically or organisationally within those trusts? And I'm not saying we will tomorrow or next week or in a few months go fully down that road, but I think it does present both a challenge and possibly an opportunity for us to think differently about the way that we might deliver services. I think this also pertains to some of those boxes, Catherine. I'm looking at you in particular around where we might end up in terms of the relationship with the voluntary sector and other organisations. And it may be that some of the hosting and the relationships that we might have with those organisations become strengthened through this, and the relationships with our physical spaces become correspondingly weakened. And in some ways, that may well pose a threat. So that's all I really wanted to say. I mean, there was something about training, and I know there are a number of trainees here. This is a nice kind of little Zoom joke about training in surgery via Zoom. But John and I and colleagues involved in delivery of training have had some discussions around how we can ensure that training as it's currently restricted isn't unnecessarily detrimental to those wanting to pursue training. So I suppose just watch this space in terms of some information coming out, either via courses that you're already enrolled on, or that we can get out via DON channels about how we will support trainees through this. I think that's probably enough right now, because we've got a few seconds remaining, but if anybody's got any comments, I imagine they've had an opportunity to type them in, and I'll keep quiet and see what you guys have seen. Is there anything up there?
I just thought it might be nice, Ingram, to add that the division is just putting together a small working group to look at or collate evidence on the sequelae of COVID-19. I mean, neurocognitive sequelae. Hugh Williams is going to lead on that in the policy unit, just for people to be aware. And I think what you're saying is quite correct. This is probably the first of a number of dialogues with members and people working in neuropsychology who are interested in how things are going to develop. This isn't the end of it.
Can I just add a comment on that as well? So that the International Neuropsychology Society, so the INS, has a COVID-19 special interest group which has just been established. And what that group is doing is trying to put together basically a protocol of tasks or tests that to try and encourage, if people are doing studies of sort of follow-up studies of neurocognitive consequences of COVID around the world, trying to encourage people to use a consistent protocol. And they're trying to break it into sort of a different levels of complexity of the or details of the test, and different stages as well. So anyone that's interested in that, have a look out on the INS website, and or if anyone wants to contact me, I can put you in touch with the people that are chairing that. The two people co-chairs of that. That work is ongoing right now, and very rapidly trying to come up with a sort of protocol that could be used internationally.
Thank you. We've run 1 minute over time. I think I just want to thank all of these guys as panelists for contributing. Nobody's charging a hefty fee for this. We've all done it in our own time, and I think to benefit our profession, our colleagues, and I'm very grateful to you for stepping up and agreeing to present today. I'm also grateful to the people who've attended for being so vibrant in your discussion and thanking us so warmly. So that's really very much appreciated. There are lots of opportunities for us to continue this discussion. I'm sure, Catherine, we've all learned a lot, haven't we, over the recent weeks, but this experience this afternoon has been an interesting one for me. I've certainly learned how to use Zoom webinars a little bit better. So thank you for that, and I'm sorry to Martin for putting little hearts all over your presentation, but it just shows how much I love you, doesn't it? So anybody got any final remarks before we draw matters to a close? I was going to suggest we maybe had 5 minutes amongst ourselves just to kind of wrap up and debrief. That might be helpful. I think we can let the attendees go unless anybody's got anything.
Yes, thank you to you as well, Ingram, for putting all this together.
It's kind of you. Thank you.
Yes, thank you, Ingram. And thank you all to the large audience that turned up and listened to us. It's much appreciated.
Yeah, likewise. Thank you. It's great. It's really nice seeing the chat coming through. Obviously, lots of kind thanks, but also lots of interesting comments about, great to have a discussion at this sort of profession-wide level with so many people being able to contribute. I mean, this is a really, really good forum for doing this sort of thing, I think, and things that, something we could continue. There's some great comments. Nice to see there's also people from, I dipping in people from Australia were on, people from Chile were on. So there's people from around the world joined us as well, which is good.
That's fantastic.
Malaysia.
Yes, clearly a huge amount of wisdom in the chat room as well. So I hope that we can capture that. I don't know how that happens.
Yeah, I was going to say the same thing.
I'll do my best. If people are, obviously we just need to make sure that nobody objects to, to their comments, but there's really useful information in the questions and the answers that people have been giving.
I think we need to keep sharing practice as well. We're all going to be trying new things, and we need to think of a way of sharing that